Okay, am I audible and visible? Yes, good evening everyone. Yes, Abhinav, Sridevi, Abhay, Lakshmi, Yuthika, Pooja. Okay, so I am audible and visible. Okay, last time. Okay, so I started with GIT. Yes, and we covered a part of esophagus. We covered a part of esophagus. We started with esophagus. And in esophagus now, I think two things were left. I was left with Barrett's esophagus and carcinoma esophagus. Okay. So these last two parts. Okay. Yes. Good evening, Ayush. Okay. So last two parts. Let us come to, yes, Akanksha. Good evening. Good evening, Akanksha. Nice to see you all today. I mean, nice to see your text today. Everyone is there. Okay. Okay. So, Barrett's esophagus. So let us come to Barrett's esophagus. Barrett's esophagus. Okay. Now I already showed you histology of esophagus last time. Yes. What is Barrett's esophagus now? Okay. Let us look at the histology once more. So if you remember, I showed you this picture. Okay. Okay. Before this, okay, I didn't show you histology. Okay, yes, Adesh, good evening. Okay. Okay, I think I didn't show you the picture of histology. I had a picture. Okay, so let us start now. Okay, I have the right file. Okay, so now I start with Barrett's esophagus. Last time I showed you the histology of esophagus. Yes. So just let's revise once again histology. Okay, so you have to know the normal histology also to understand the pathology. Okay, so we did it. We did this last time also. Okay, so first in the esophagus. Okay, so in the esophagus, number one, this is the, what I have marked in green, this is the epithelium. Okay, lining epithelium. So what is the epithelium of esophagus? This is stratified squamous epithelium. It is, so you already know, you people have done, you have done anatomy. So this is stratified squamous epithelium. So in the esophagus, you have the mucosa. Mucosa is lined by, so you have the mucosa. In the mucosa, what do we have? We have the epithelium. Epithelium. And what is the epithelium in the esophagus? It is stratified squamous epithelium. So which is the esophagus epithelium of the esophagus? Stratified squamous epithelium. So in the mucosa, number one, you have the lining epithelium. Below that, below the epithelium, we have the lamina propria. These are all parts of epithelium. Lamina propria, and then, so lamina propria, okay, and then you have, so this is the mucosa. Then second layer is the submucosa. Submucosa. So submucosa has been marked here. You can see there is submucosa. So in the epithelium, these are the three layers. In the mucosa. So mucosa has three parts. Number one, mucosa has the lining epithelium. What is the lining epithelium of esophagus? It is the stratified squamous epithelium. Then below the epithelium, you have the lamina propria. Okay, we have the lamina propria. And then below the lamina propria, we have a tiny layer of muscle called muscularis mucosae. So muscle layer associated with mucosa, that's called muscularis mucosae. So double M here is labeled in your picture. So EPI, okay, look at the labels. EPI is the stratified squamous epithelial lining. LP is the lamina propria. Double M is the muscularis mucosae. Then second layer of esophagus labeled in blue. So this was the first layer. Second label in blue is the submucosa. Then third layer is the muscularis externa, which is the muscle coat. And last is the fourth layer is the adventitia. Okay, if you look at the muscularis externa has two layers of muscle, inner circular and outer longitudinal. So IC is inner circular, OL is outer longitudinal, and then you have the adventitia. So important is, what I want to highlight here is esophagus is lined by stratified squamous epithelium. So what is the lining of esophagus? The lining of esophagus is stratified squamous epithelium. Okay, now let us come to what is Barrett's esophagus. So now look at this part. Okay, can you see this is esophagus? Picture, look at A, this is the normal esophagus, and it is lined by stratified squamous epithelium. And when you see the esophagus under the microscope, this stratified squamous epithelial lining, this is seen as pinkish white area. Okay, second, now what is Barrett's esophagus? So I'm going to write what is Barrett's esophagus. Barrett's esophagus is stratified squamous epithelium goes away and that gets replaced by intestinal type of epithelium. Intestinal epithelium, what does intestinal epithelium has? Intestinal epithelium has columnar cells. Not stratified squamous cells. Intestines have columnar cells and goblet cells. So now columnar epithelium is coming and replacing the stratified squamous epithelium. So you can see, and goblet cells have been labeled. Goblet cells are these clear looking cells. They are the goblet cells. So they come, and the area of Barrett's esophagus looks reddish velvety in appearance. So you can see this appearance reddish velvety. So let me first write down and then you can see, okay, what is Barrett's esophagus? Barrett's esophagus is that there is replacement of stratified squamous epithelium. Replacement of stratified squamous epithelium by, what is it replaced by? By columnar epithelium. Columnar epithelium with goblet cells. With goblet cells. Yes, Adesh, very good. With goblet cells, that's called intestinal metaplasia. What is that? It's basically intestinal metaplasia. So stratified squamous epithelium is going away, and in place of that, intestinal type of epithelium, that is columnar cells with goblet cells, is coming. That's called intestinal metaplasia. And this is happening in lower one third of esophagus. Lower one third of, where is this happening? Lower one third of esophagus. Okay, now by endoscopy. If you look at the areas of Barrett's esophagus by endoscopy, areas of Barrett's esophagus, they have red velvety appearance. So areas of Barrett's esophagus, what type of appearance do they have? They have red velvety appearance. Okay, cause. What is the cause of Barrett's esophagus? Very important cause of Barrett's esophagus is the stomach contents are coming into the esophagus. That is called gastroesophageal reflux disease. So this is for more than 5 to 10 years old. So GERD, what is GERD? Gastroesophageal reflux disease. So chronic GERD, basically chronic GERD, that is there for more than 5 years. More than 5 to 10 years. Okay, more than 5 to 10 years. Also more associated with obesity. Males more common than females, and age is usually more than 50 years. So risk factors for Barrett's esophagus, better than cause, we say risk factors are chronic GERD. Chronic means more than 5 to 10 years of age. Obesity, more than 50 years of age. Okay, clinical features, what does the patient come with? Patient will present with heartburn and regurgitation. So heartburn and regurgitation. So patient comes with heartburn and regurgitation. And now last very important point, Barrett's esophagus is a precancerous condition. Precancerous, and it is associated with, there is increased, these patients are at increased risk of developing adenocarcinoma. Adenocarcinoma esophagus. So they are at increased risk of developing adenocarcinoma esophagus. So this is about Barrett's esophagus. So look at the picture once more now. So you can see normal esophagus. Picture A is normal. B is endoscopy, where normal is appearing whitish in color, pinkish white, whereas areas of Barrett's are reddish. So they have a red velvety appearance. And you can see columnar cells with goblet cells. So they are replacing the esophagus. So you can look at the type of question. A 45-year-old Caucasian male presents to gastroenterologist complaining of heartburn and difficulty in swallowing. He recalls that he has been told by his primary care physician that he suffers from, yes, very good, Adesh. I'm going to talk about that also. I'll tell about Alston-Blow also. That he suffers from gastroesophageal reflux disease. The gastroenterologist decides to perform an upper GI endoscopy with biopsy. So what is the gold standard for diagnosis of Barrett's esophagus? Upper GI endoscopy with biopsy. This is the gold standard for diagnosis. So how will you diagnose Barrett's? Do an endoscopy, upper GI endoscopy, and then do a biopsy. Which of the following findings are consistent with Barrett's esophagus? Okay, which of the following findings are consistent with Barrett's esophagus? So quickly mark the answer. Mark the answer. All of you. And also I want to tell, if you want to highlight these goblet cells, so what is intestinal metaplasia? You will have tall columnar cells with goblet cells. So if you want to highlight the goblet cells, the special stain that we use is Alcian blue. Yes, so the stain is Alcian blue. So special stain is Alcian blue. So yes, okay. Adesh, yes, Adesh, absolutely correct. Answer is 3. A small region of red velvety mucosa in the lower esophagus. So Ayush, Adesh, Sridevi, all of you are correct. So answer is 3 or answer is C. Yes. So Abhay also, Abhinav, yes. Abhinav also. All of you are correct. So yes, Yutika, absolutely correct. Answer is C. So red velvety mucosa in the distal 1/3, lower 1/3 of esophagus, special stain. So you see columnar cells with goblet cells. If you want to highlight these goblet cells, the special stain that you will use is Alcian blue. And as Sridevi has rightly pointed out, Alcian blue stains the acidic mucins. Okay, so that is not very important for you, but just remember the stain of Alcian blue. Okay, now second, let's come to esophageal cancer, esophageal carcinoma. Okay, esophageal. Yes, Pooja, absolutely right. Pooja also is correct. Answer is 3. Okay. Now esophageal cancer. Okay, number 1, esophageal cancer clinical feature. How does patient of esophageal cancer present? They have progressive dysphagia. Number 1, progressive dysphagia. And dysphagia is first for solids and then even for liquids. First for solids and then even for liquids. So they have dysphagia. Dysphagia is first for solids, then even not liquids. Second, they have weight loss. Dysphagia, weight loss. Okay, so yes, very good, Sridevi. Okay, second, weight loss, and third is very important, it carries a poor prognosis. So esophageal cancer carries a poor prognosis. Okay, second, now there are 2 main histological types of esophageal cancer. Two histological types of esophageal cancer. So you have to know which type is more common in the world. So 2 main histological types. These are number 1, squamous cell carcinoma, and second is adenocarcinoma. So 2 main histological types of esophageal cancer, they are squamous cell carcinoma and esophageal cancer. Okay, first is prevalence. Let us look at the prevalence. Then we will see part of first location. Let us look at the location. Where do you find squamous cell carcinoma? Squamous cell carcinoma is usually located in the upper 2/3 of esophagus. So location, squamous cell carcinoma, usually in the upper 2/3 of esophagus. Whereas adenocarcinoma is usually located in the lower 1/3. Adenocarcinoma is located in the lower 1/3. Okay, second, let us look at risk factors. Risk factors for squamous cell carcinoma. Okay, risk factors for squamous cell carcinoma are number 1, hot liquids, ingestion of hot liquids, or caustic strictures. So if somebody has ingested acids or alkali and that leads to formation of strictures, those strictures can become malignant. Okay, third is achalasia cardia, which we already read, achalasia. Then smoking, alcohol. So smoking, alcohol, and one more factor is what we call as Plummer-Vinson syndrome. I have told you in Plummer-Vinson, I have already talked about Plummer-Vinson syndrome. I have already told you about Plummer-Vinson and iron deficiency anemia. So Plummer-Vinson syndrome, it's a triad of iron deficiency anemia. IDA stands for iron deficiency anemia, comma, dysphagia due to upper esophageal webs. So patient has Iron deficiency anemia, he develops webs in the epithelial webs in the upper esophagus, because of which he has dysphagia for solid foods. And third, atrophic glossitis. Atrophic glossitis. This is Plummer-Vinson syndrome. Patients with Plummer-Vinson are at increased risk of developing squamous cell carcinoma. Okay, so second, risk factors for adenocarcinoma. Risk factors for adenocarcinoma, number one, chronic GERD. So chronic GERD, you know, that leads to Barrett's esophagus. Barrett's esophagus. Barrett's esophagus. Okay, and that leads to esophageal adenocarcinoma. Then achalasia. Achalasia is can predispose to both squamous and adenocarcinoma. Then smoking again can predispose to both squamous and adenocarcinoma. And then of course we have obesity and radiation for adenocarcinoma. Okay, obesity and radiation for adenocarcinoma. Okay, then prevalence. Which is more prevalent where? Okay, prevalence more common in the world is squamous cell carcinoma. More common in India and in the world. So everywhere else in the world, this is more common. Whereas in America, more common in West or in America. So more common in America or in the West is adenocarcinoma. So adeno is more common in the West. Okay, and last is gross. If you see, how does squamous cell carcinoma look like when it comes to the esophagus? Squamous cell carcinoma usually presents as an exophytic mass. So it presents as an exophytic mass. So exophytic mass. And you know, as Sridevi has rightly pointed out, what will you? Okay, Adesh, you know, you've asked me why not radiation in SCC. See, usually it is radiation is associated with adenocarcinoma, not with SCC. Okay, of course, SCC, but I'll still check. Why not? You are asking me why not SCC, but usually what we have seen in esophagus, it is the radiation exposure gives rise to adenocarcinoma. Okay, maybe it is how we give the radiation. I'll check this and let you know. Okay, so this presents as an exophytic mass, whereas in case of adenocarcinoma, grossly it presents, it is usually not an exophytic mass, either it's a flat lesion or it is an ulcer or an ulcero-proliferative lesion. So it is either flat, ulcerative or ulcero-proliferative lesion. So it presents like that, whereas squamous will present as an exophytic mass. And microscopy, if you see in squamous cell carcinoma, the malignant cells are squamous cells. So you see squamous cells. In adenocarcinoma, malignant glands are formed. Okay, so in adenocarcinoma, you have malignant glands. So here what do you have? Malignant squamous cells. You'll see malignant squamous cells in sheets. They will be present in sheets. And yes, Sridevi, adenocarcinoma is the most common cancer, more common in US. America is US, so in America, adeno is more common. Okay, malignant, so microscopy in squamous cell carcinoma, you have malignant squamous cells in sheets, and sometimes you can even see something called as keratin pearls. So these squamous cells, they form pink colored whorl structures called keratin pearls. And in adenocarcinoma, you have malignant glands. You see malignant gland. So it's an edema, so you see malignant gland. So that is about carcinoma esophagus. Okay. So let me just show, okay, carcinoma esophagus. Okay. Now let us come to stomach. Okay. First, let's again look at the normal histology of the stomach. So again, in stomach, you will have everywhere in GIT, we have 4 basic layers. Which are they? Number 1, mucosa. Number 2, submucosa. Number 3, muscularis propria. Entire whole GIT, starting from esophagus down, these are the 4 layers. Epithelium, lining epithelium will differ. 4th is now in stomach, the last layer, we don't call it adventitia, we call it serosa. Again, mucosa has 3 parts as everywhere else. Mucosa has the epithelium, mucosa has the lamina propria LP, and it has the muscularis mucosae, a tiny layer of muscle associated with mucosa. So now look at this. This is the section from stomach. So what you see here, this part I'm labeling till muscularis mucosae. This is the mucosa. This is the mucosa. You can see, okay, I think, so this whole part is the mucosa. So you can see the lining epithelium. Okay, okay, Adesh, see, you do have to read all this. Okay, now, I understand what you are saying, but you know your questions, how your questions are based. They can put these risk factors in the questions and make a question. Okay, so so you have to try and remember. Of course, if you you know your MLE questions are good. I like those questions. Why? Because even if you've forgotten that obesity is a risk factor, that question is going to give you many more pointers pointing towards esophageal cancer, towards adenocarcinoma, or towards squamous cell carcinoma. Okay, so you require repeated reading, of course, as many as you can remember, but of course the question will not be based on the risk factor alone. There will be many more pointers or many more other facts in that about that tumor, in your question about that tumor. Okay, Sridevi, you asked me small cell carcinoma, but small cell carcinoma esophagus is a very rare entity. The two cancers are adeno and squamous. So you have to learn these two. No need, you are not going to become a pathologist. Okay, I need to know about small cell carcinoma. You don't need to know. Okay, so small cell carcinoma you have to remember in lungs. In lung, don't forget small cell carcinoma. So when we do lung cancer, small cell carcinoma is very important. So in lungs, we have small cell carcinoma, squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. There you have to remember small cell. Okay. Small cell carcinoma can occur in the esophagus, but extremely rare. Okay, now let us see. First, this is the, so you can see the mucosa. So mucosa is having these gastric pits are labeled. So mucosa is lined by columnar cells. These are columnar cells. Then below in the lamina propria, we have these gastric glands. Then you have this muscularis mucosa. Then below the mucosa, there's a layer of submucosa. Below the mucosa, there's layer of submucosa. Then, so this is the submucosa here. So below the mucosa, what is not labeled here is the submucosa. This is the submucosa. Below the submucosa, you have this muscle layer. Now in stomach, the muscularis propria, it has three layers. It has three layers. It has the oblique layer, it has the circular layer and the longitudinal layer. And last layer, which has not shown in this picture, is the serosa. Okay, now epithelium. Look at the epithelium of the stomach. Stomach is lined by, the epithelium is tall columnar cells. So it is lined by tall columnar cells. And these cells, you know, they produce mucus. These are mucus producing cells. And these tall columnar cells, they are also called foveolar epithelial cells. What are they called? They are called foveolar epithelial cells. So the lining epithelium, what I am labeling in red now, I have marked these. The lining epithelium of stomach is tall columnar cells. They produce mucus, and these cells are called foveolar epithelial cells. The foveolar epithelial cells. Oh, I'm happy. If more and more of you become pathologists, I'll be very happy, Sridevi, and for everyone. Okay, and outside India, where you want to go, I hope all of you go where you want to go. The pathology also gets a lot of weightage. So you get, I mean, if you become a pathologist, a histopathologist, or a cytopathologist, you can do so many specializations further in pathology also. So it's a very good branch. Okay, so the epithelium is lined by tall columnar cells. These are called foveolar epithelial cells, and they secrete mucin or mucus. Okay, then second, in the stomach, in the body, in the lamina propria of the stomach, if you look at lamina propria or in the mucosa, in the lamina propria of the stomach, of fundus and body of stomach. If you look at the, if you do the histology of fundus and body of stomach, in the lamina propria, we have these gastric glands. What do you have? You have gastric glands. Okay, you have these gastric glands, and these gastric glands, they contain chief cells. You already know this. These gastric glands contain chief cells and parietal cells. They contain chief cells and parietal cells. Chief cells, what do the chief cells produce? They produce enzymes that help in digestion of food. And what do parietal cells produce? Two things. You already know this. Normal parietal cells produce hydrochloric acid, HCl, and two, they produce intrinsic factor. They produce intrinsic factor. Intrinsic factor is needed for absorption of vitamin B12 from the ileum. So this is the normal histology of the stomach. So 4 layers anywhere in the GIT: mucosa, submucosa, muscularis propria, and serosa. Mucosa further has 3 parts: the lining epithelium, lamina propria, and muscularis mucosae. In the stomach, the lining epithelium of the mucosa is tall columnar mucin secreting cells, which are called foveolar epithelial cells. Then in the lamina propria of stomach, especially in the fundus and body of the stomach, you have gastric glands. Gastric glands have chief cells and parietal cells. Chief cells produce enzyme, parietal cells produce hydrochloric acid and intrinsic factor. Okay, now with this background, now let us start with, in stomach we have to start with gastritis. Okay, before I start with, I'll be doing gastritis, acute gastritis and chronic gastritis. Now, before gastritis, before gastritis, normally if you see, so this is the stomach here, what you see, this is the stomach, this is the epithelium, lining epithelium. Okay, if you see stomach, the stomach produces acid. Stomach produces acid and pepsin, enzyme pepsin. Isn't it? The chief cells, they produce enzymes. One of the enzymes is pepsin. So the stomach produces acid, that is hydrochloric acid, and pepsin, enzyme pepsin. Both these things, acid and pepsin, they are capable of damaging the epithelium of stomach. They are capable of damaging the foveolar epithelial cells. They are capable of damaging the mucosa of the stomach. Both acid and pepsin, they can digest the mucosa of the stomach also, but that doesn't happen normally. Why? Because there are certain defense forces which the stomach has, which protect it from acid pepsin digestion. So the stomach is protected. Stomach produces pepsin, enzyme pepsin. Stomach produces enzyme, produces hydrochloric acid. Both hydrochloric acid and enzyme pepsin can digest even the mucosa. Not only digest the food, they can even digest the mucosa of the stomach. But mucosa of the stomach doesn't get digested. It remains happy. It remains intact because there are certain defense mechanisms which the mucosa has. They are, number one, surface mucus secretion. So the foveolar epithelial cells, they produce lots of mucus, and this mucus covers the epithelial layer. It is like a protective sheet on the epithelial layer. Second, bicarbonate secretion in the mucus. So in the mucus there are bicarbonates, and these bicarbonates take care of the acid, HCl. Third, mucosal blood flow. A lot of blood flows into the mucosa, and this blood flow helps to wash away all the toxins and thus protects the mucosa from getting damaged. Then third, apical surface membrane transport is there, something. Then the epithelium of the stomach has a very good regenerative capacity. If the cells die, new ones quickly come, so they regenerate. And last is the epithelium produces prostaglandins. So prostaglandins, by Cox pathway, cyclooxygenase pathway, in the epithelium prostaglandins are produced. Important ones are PGE2 and PGI2. These two prostaglandins are produced, and these two prostaglandins, they are very important defense forces. These prostaglandins, what do? They increase mucosal blood flow, they increase the bicarbonate secretion, they increase the mucus secretion. So all the above, prostaglandins have all the above actions. So these are the defense forces. Okay. Now, when can ulcers, whether it is acute gastritis or chronic gastritis and ulcers, when can they form in the stomach? So ulcers can form in the stomach, number one, if there is impaired defense. So these defenses which I have told, if they are impaired defenses. So when do you see impaired defenses? So when can ulcer form in the stomach? If these defenses are not there. So if these defenses are impaired, acid and pepsin will act on the epithelium and cause damage to the epithelium. So impaired defenses are seen in ischemia. Ischemia means enough blood is not coming into the stomach. So if enough blood doesn't enter the mucosa, toxins are not washed away and mucosa will not be able to regenerate. Even prostaglandins will not be able to be produced. Second, shock. Again, in shock there is ischemia, delayed gastric emptying, and duodenal gastric reflux. If duodenal contents are coming into the stomach, then also, so all these are impaired defenses. Another cause for formation of ulcers in the stomach is increased aggression. Increased aggression means if this gastric acidity increases or if peptic activity increases, then also. So here, number one causes are H. pylori infection. So we will see what H. pylori does. NSAIDs, non-steroidal anti-inflammatory drugs like aspirin, cigarette, alcohol, and impaired regulation of acid pepsin secretion. So these are the aggravating causes which can cause damage to the gastric mucosa. Okay, so now with this background, let us start number one with gastritis. Gastritis. Okay, very simple terms. What is gastritis? Gastritis is inflammation of stomach. Inflammation of stomach is called as gastritis. Gastritis is of two types, acute gastritis and chronic gastritis. So it's of two types, acute and chronic. Okay, first acute gastritis. Acute gastritis. Acute gastritis is also called acute erosive gastritis. Erosive gastritis. So it's also called acute erosive gastritis because in the stomach there are erosions. Erosions means the mucosa is damaged. The mucosa gets damaged. Okay, now so acute gastritis is inflammation of the stomach. It's also called acute erosive gastritis. If you see under the microscope in acute gastritis, you will see in the gastric mucosa, you will see acute inflammatory cells. Which are the acute inflammatory cells? They are neutrophils. So in acute gastritis on microscopy, you see neutrophilic infiltration. Neutrophilic infiltration in the mucosa. In the mucosa. So in the mucosa of the stomach, lots of neutrophils will be sitting. Okay, and it's erosion. So erosion means erosion is like an ulcer, little short of ulcer. So it is a defect in the mucosa. What is erosion? Erosion means defect in the mucosa. Defect in the mucosa. So erosion is a defect in the mucosa. Okay, so now what are the causes or what are the causes of acute gastritis? Causes are number one, first NSAIDs. NSAIDs. So you saw what do NSAID do? They are the aggressive factors. What do NSAIDs do? So non-steroidal anti-inflammatory drugs like aspirin. Aspirin, you all know aspirin and NSAIDs, they are COX inhibitors. They inhibit COX, cyclooxygenase. So if COX gets inhibited, what will happen? Prostaglandin decreased, PGE2 and decreased PGI2. So these two prostaglandins, PGE2 and PGI2, they are produced by COX pathway. So these NSAIDs inhibit COX. So PGI2 and PGE2, these two prostaglandins will not be produced. So when these two prostaglandins are not produced, this leads to decreased mucosal protection. Also the mucosal blood flow also reduces. So also there is decreased mucosal protection, mucosal blood flow, all those factors are reduced. Okay, first is NSAIDs. Second, what is the second etiology of acute gastritis? So second etiology of acute gastritis, second is burns. Burns can cause acute gastritis. Okay. Now in patients with burns, a number of burns patients can have a number of ulcers or erosions in their stomach. And these are called as curling ulcers. C-U-R-L-I-N-G. Curling ulcers. So burns can cause development of numerous ulcers in the stomach called curling ulcer. So what is the reason? In burns, in patients with, this is seen in severe burns. In patients with severe burns, they get dehydrated. They lose a lot of their fluid. So there is hypovolemia. hypovolemia. So they have hypovolemia, and because of decreased blood volume, this leads to mucosal ischemia. So ischemia. So here the cause is ischemia. So burns cause ischemia of the gastric mucosa. Ischemia leads to erosions. So the defense mechanism decreases. Okay. Third is patients with brain injury can also cause acute gastritis. Can also have acute gastritis, and the ulcers that form in patients with brain injury, the ulcers that form in the stomach are called Cushing's ulcers. Cushing, C-U-S-H-I-N-G, Cushing ulcer. Okay, now what is the cause for in brain injury? Why are the ulcers formed in the stomach? In brain injury, whenever brain is injured, there is increased vagal stimulation. There is increased vagal stimulation. Increased vagal stimulation, and increased vagal stimulation, this will lead to increased HCl production. Increased HCl production. Increased vagal stimulation leads to increased HCl production. Okay, other than this, acute gastritis can also be caused by alcohol. Alcohol can also cause acute gastritis. Alcohol acts in a number of ways. Alcohol irritates the gastric mucosa. So alcohol causes damage by a number of mechanisms. So alcohol can also damage. So alcohol, it irritates the gastric mucosa. Irritates the gastric mucosa. It irritates the gastric mucosa. Okay, so now this is acute gastritis or acute erosive gastritis, where in patients with burns, you have Curling's ulcers develop in the stomach, and in patients with brain injury, Cushing's ulcers develop. In addition, patients with on NSAIDs and even who take in a lot of alcohol, they can have this. So this is especially common among. So if a patient is an alcoholic, and to talk to that, he has NSAIDs also. And so patient is an alcoholic, 1 or 2. If people say they have rheumatoid arthritis or some other disease, if they are taking daily NSAIDs also, then they end up with acute gastritis. So alcoholic patient and patients with diseases like rheumatoid arthritis who are taking NSAIDs daily, they can end up with acute gastritis. They can end up with acute gastritis. Okay, so this is acute erosive gastritis or acute gastritis. Second is chronic gastritis. Chronic gastritis. Okay, chronic gastritis, or it's also called chronic. Now this is non-erosive, chronic non-erosive gastritis. So here now in chronic gastritis, you don't see erosions in the stomach. So it's non-erosive gastritis. And under the microscope, what will you see? In acute gastritis, we saw neutrophilic infiltrate in the mucosa. Here, what will we see? You will see chronic inflammatory cells in the mucosa. So you see mucosal inflammation, mucosal infiltration by chronic inflammatory cells. So in the mucosa now, chronic inflammatory cells of chronic inflammation, they will come. Chronic inflammatory cells. So mucosal infiltration by chronic inflammatory cells like lymphocytes, plasma cells, plasma cells and macrophages. Lymphocytes, plasma cells and macrophages, these cells infiltrate the mucosa of the stomach in chronic gastritis. Okay, mucosa. Okay, now what happens? So these chronic inflammatory cells come in the stomach, they infiltrate the mucosa. Now what happens? This chronic inflammation, it causes damage to it causes atrophy of the mucosa. And in the mucosa, you have lamina propria, and in the lamina propria, you have the gastric glands. So all this inflammation, what does it cause? It causes atrophy of the mucosa. Atrophy of mucosa. Okay, now when the mucosa gets atrophied, what will happen? The parietal cells and the other cells, they will reduce. So they become less. So this leads to less acid will be produced. So this leads to hypochlorohydria. So decreased acid production or hypochlorohydria. Decreased acid production or hypochlorohydria. Okay, so decreased acid production, and when and so there's decreased acid production or hypochlorhydria. And second is whenever there is atrophy of the mucosa. So chronic gastritis is ultimately causing atrophy of the mucosa. So whenever there is atrophy of the mucosa, atrophy can lead to intestinal metaplasia. So atrophy can lead to may lead to intestinal metaplasia in stomach. So intestinal metaplasia, and this intestinal metaplasia increases the risk of developing gastric carcinoma, gastric adenocarcinoma. So this increases the risk of developing. So whenever there is atrophy of the stomach, gastric mucosa, that predisposes to intestinal metaplasia, and intestinal metaplasia can increases the risk of developing gastric adenocarcinoma. So adenocarcinoma of the stomach. Okay, now two main etiological factors for chronic gastritis are, so two main etiological factors, so etiology. Two main etiological factors for chronic gastritis are, so two main, etiology, two main etiological factors. Two main etiological factors are, number one, H. pylori gastritis. H. pylori causing gastritis. So two main etiological factors are H. pylori gastritis, and second is autoimmune gastritis. So two main types or two main etiological factors are H. pylori causing H. pylori causing chronic gastritis, and autoimmune gastritis. Autoimmune gastritis. So these are two main types of chronic gastritis or two main etiological factors. In H. pylori gastritis, it is H. pylori that causes the, okay, now first is H. pylori. H. pylori stands for Helicobacter pylori. Bacter pylori, which is a gram-negative bacteria. Gram-negative bacteria. And you know what is the shape of H. pylori, gram-negative bacteria? It is curved and flagellated bacteria. So H. pylori infection can cause chronic gastritis. H. pylori is a curved and flagellated bacteria, and you know H. pylori loves to infect the antrum of the stomach. So it infects, H. pylori is a curved and it's a gram-negative bacteria, it's a curved and flagellated bacteria, and it infects the antrum of stomach. Which part does it love? Antrum. So it infects the antrum and it causes antral predominant gastritis. So it causes antral predominant gastritis. So gastritis which is predominantly in the antrum. And then complications, what all can H. pylori gastritis lead to? This H. pylori gastritis, number one, it can lead to peptic ulcers. So patients with H. pylori gastritis can develop peptic ulcers. Second, H. pylori gastritis patients can also develop marked lymphomas of stomach. And third, H. pylori gastritis patients can also develop adenocarcinoma stomach. So adenocarcinoma is less common. More common is they develop marked lymphoma. So marked lymphoma more common than adenocarcinoma. And very important, cause of peptic ulcers is also H. pylori. It causes H. pylori and it infects the antrum of the stomach. Later it causes antral predominant gastritis. So H. pylori first infects antrum and it causes antral predominant gastritis. Later it can even spread to body of stomach. When H. pylori infection spreads to the body of the stomach also, then it causes pangastritis. And patients with this pangastritis, they are at increased risk of developing adenocarcinoma, because you know pangastritis will lead to atrophy of stomach. So this will lead to atrophy of the mucosa. So it will cause atrophy of the mucosa. So that is H. pylori gastritis. Okay, once again, A very important cause for chronic gastritis is H. pylori infection. H. pylori is gram-negative, curved and a flagellated bacteria, and it infects the antrum, and usually it causes antral predominant gastritis. And patients with antral predominant gastritis, long-standing, if the infection is not treated, they can develop peptic ulcers, one. Two, marked type of lymphoma. They can develop, it can evolve into marked type of lymphoma, rarely adenocarcinoma. Adenocarcinoma usually occurs when H. pylori infection from the antrum, it spreads to the body of the stomach as well. And that's called pangastritis. So the entire stomach is inflamed, and then it leads to atrophy of the gastric mucosa, leading to increased risk of adenocarcinoma. So that is H. pylori gastritis. Okay, one more point here I'll write down. Now there is if you want to see H. pylori in the stomach, you can do a gastric biopsy and look for H. pylori. We use a special stain for H. pylori called Wardenstari. Wardenstari. So which is the stain used to demonstrate H. pylori? Wardenstari, which is a silver stain. Silver stain, and on the stain H. pylori appear black in color. So what is the color of H. pylori? H. pylori appear black in color by Wardenstari stain. So let us see this picture. Okay, so let us see. Okay, look at this question. Okay, look at this question first, then we look at H. pylori. A previously healthy 24-year-old male is admitted to ICU intensive care unit following a motorcycle crash. So motorcycle crash, he has sustained head injury requiring an emergency craniotomy, has burns over 30% of his body, and has fractured his humerus. His pain is managed with continuous fentanyl infusion. 2 days later, after admission to ICU, he developed severe hematemesis. Which of the following mechanism underlines the development of this hematemesis? So what is the answer to this? What is the answer to this? Okay, what do you think is the answer to this question? Okay, 4. Okay, Ayush, yes, 4. Okay, so here now patient has burns also. Sridevi, okay, vagal stimulation. So he has a head trauma which has led to vagal stimulation, which has led to increased acid production. Okay, so that increased gastric acid production, yes. And second, there is gastric mucosal disruption also because of these burns that the patient has. So here now, number 1, because of head injury, this leads to vagal stimulation and increased acid production, increased gastric acid production. Okay, and plus now there are burns, and this leads to in burns, there is hypovolemia. So decrease mucosal blood flow. And what will decrease mucosal blood flow lead to? Decreased mucosal blood flow will lead to gastric mucosal disruption. So both these factors are operating here. So answer is yes, Rishita is correct. So answer is 1 and 2. So answer is 4. Abhay is also correct. So answer is 1 and is 4. That is answer 1 and 2. Okay. Okay, I'll show you. Okay, now look at this question. So look at this question. A biopsy of the antrum of the stomach of an adult who presents with epigastric pain reveals numerous lymphocytes and plasma cells within the lamina propria, which is of normal thickness. There are scattered neutrophils within the glandular epithelial cells. A Steiner silver stain. So Steiner or Wardenstari, they are the same stains. Steiner stain, or also another silver stain that we do is Wardenstari. So Wardenstari or Steiner, Steiner stains. Both these are silver stains. For the specimen is positive for small curved organism. These histological changes are most consistent with infection with which of the following? So answer here is C, that is H. pylori. Okay, now I want to show you, this is, you can see This is the silver stain, and these numerous black colored on the top of the epithelium. This is epithelium. These numerous curved bacteria, black colored, all these are H. pylori. So these numerous tiny black bacteria, all these are H. pylori. Yes, Abhinav, Pooja, all of you are correct. So look at this. I have zoomed this picture. All these black colored bacteria, which they are curved, looking something like this, they are all H. pylori. Okay, so this is H. pylori. Silver stain like Stainer or Wardenstari can be used to demonstrate this H. pylori. Okay, so this is H. pylori infection. Okay, now second gastritis, second cause of chronic gastritis is autoimmune gastritis. So let us look at second. Second is autoimmune gastritis. So second is autoimmune gastritis. Okay, coming to autoimmune gastritis. Okay, now autoimmune gastritis, okay, you know which cells H. pylori. Okay, Ayush, okay, why antrum? Also why antrum? Okay, antrum is the ecological niche of H. pylori. We use the term ecological niche. It loves to go to the antrum. Okay, probably in the antrum of the stomach compared to the body, the acid is little less, probably. Okay, because you know how does now which cells does it colonize? Okay, so the ecological niche of H. pylori is antrum. Number one, probably there the acid is slightly less. Okay, and you know H. pylori, it stays on top of the epithelium. You have the mucus layer, mucus layer. It remains in the mucus layer, and then it attaches to the foveolar epithelial cells. Just the surface epithelial cells I showed you, they are the foveolar epithelial cells. So it colonizes the foveolar epithelial cells, which are the mucus secreting cells. Okay, now you know the pH of the stomach is so acidic. Even in the antrum, the acidity is slightly less, but still it is acidic. So, you know, H. pylori, it produces enzyme urease. And urease, you know, in our blood, there is urea. In the stomach blood also, the blood that is coming into the stomach, there is urea. So this urease enzyme acts on the urea and generates ammonia. And that ammonia forms an alkaline cloud around the bacteria, and thus the bacteria is able to survive in the stomach. So it survives in the stomach. And you know, second, it has flagella. Flagella help it to move around in the mucus. So probably one of the reasons it colonizes the antrum is as compared to the body here, the acidity is slightly less. And then it by means of it has those and the cells, as you've asked, the cells that it colonizes attaches to foveolar epithelial cells of the stomach, and then it causes chronic inflammation. In that chronic inflammation, you have lymphocytes, plasma cells, macrophages, and as I showed you in the question, in H. pylori gastritis, you also have neutrophils. So in H. pylori gastritis, microscopy, you have, like in any other chronic gastritis, you will have lymphocytes, plasma cells, macrophages, plus also neutrophils, which was there in your question. Okay, now coming to autoimmune gastritis. As the name suggests, autoimmune. So in autoimmune gastritis, antibodies are produced. So it's an autoimmune disease where antibodies are produced against the parietal cells and intrinsic factor. So antibodies are produced against the parietal cells and intrinsic factor. Okay, so now these antibodies, what do? Antibodies destroy the parietal cells. So what do the antibodies do? They destroy the parietal cells. So antibodies are produced, they destroy the parietal cells. So now you know parietal cells are responsible for producing hydrochloric acid. So no HCl. This results in, okay, so first autoimmune gastritis, antibodies are produced against parietal cells and intrinsic factor. And you know, parietal cells, where are they located? Most abundant? They are most abundant in the fundus and body of the stomach. Fundus and body. Against parietal cells and intrinsic factor, where are the parietal cells? In the fundus and body. body of stomach. Okay, so these antibodies, so these antibodies destroy the parietal cells, so no hydrochloric acid. This produces achlorohydria. Achlorohydria. What does the term achlorohydria means? Absence of hydrochloric acid. 1. 2. No intrinsic factor. Intrinsic factor is also destroyed. So no intrinsic factor. This will lead to, intrinsic factor is needed for absorption of vitamin B12 from the ileum. So vitamin B12 is not absorbed from the ileum. As intrinsic factor is not there. So this produces megaloblastic anemia. So what does this lead to? This produces megaloblastic anemia. And third is now antibodies are against the parietal cells located in the fundus and body. So now this causes atrophy of gastric mucosa in fundus and body. So in the fundus and body, the parietal cells are getting destroyed. So there is atrophy of the gastric mucosa. Now atrophy, predisposes to intestinal metaplasia. And now this predisposes to increased risk of gastric adenocarcinoma. So this leads to increased risk of gastric adenocarcinoma. Okay, now and one more point, this megaloblastic anemia, which happens in patients with the autoimmune gastritis, this megaloblastic anemia is called pernicious anemia. And this gastritis, which predominantly affects the fundus and the body, because these parietal cells are located in the fundus and the body. So this gastritis is called antral sparing. So it's called type A. So autoimmune gastritis is called type A or antral sparing gastritis. Antral sparing gastritis. So it's type A gastritis or antral sparing gastritis. It spares the antrum, involves the fundus and body. In contrast, let us come back here. In contrast, this H. pylori gastritis, it's called antral predominant gastritis. As we saw it's called antral predominant gastritis, or it's also called type B gastritis. So it's called antral predominant or type B gastritis. So antral predominant or type B gastritis. Okay, so this is about second very important type of gastritis, that is autoimmune gastritis, which is antral sparing, involves the fundus and the body of the stomach predominantly, and is associated with achlorohydria, pernicious anemia, which is the megaloblastic anemia, and increased risk of developing gastric adenocarcinoma. Okay, coming to the next entity in this category. Next entity is Menetrier's disease. Menetrier, Menetrier disease. So next is Menetrier disease. Menetrier disease is also called hypertrophic gastropathy. Gastropathy. Okay. Now I showed you the picture of normal histology of stomach. There is mucosa. In the mucosa, what is the lining epithelium? Columnar cells, which produce mucus, and these cells are called foveolar epithelial cells. What are they called? Foveolar epithelial cells. And then in the lamina propria, you have gastric glands, and then you have the muscularis mucosa in the mucosa. So that's the mucosa. Then you have the submucosa, then you have the muscle coat or muscularis propria, and then you have the serosa. Okay, now what is this Menetrier's disease? Okay, in Menetrier's disease, there is hyperplasia of the foveolar epithelial cells. So it's called hypertrophic gastropathy, and it is characterized by, number one, there is hyperplasia of foveolar epithelial cells. So what happens? There is hyperplasia of these. So what are the foveolar epithelial cells? You already know they are the cells lining the the epithelial cells of the stomach that line the epithelium. So these are foveolar epithelium. They undergo hyperplasia. Then I have already told you they are mucus producing cells. So now there is hyperplasia of the foveolar epithelial cells. As a result, there is lots and lots of mucus production is there. Mucus production is there. So lots and lots of, so in the stomach, lots of mucus is produced. Okay. Now when this mucus is produced, what will happen? You know, in the lot of mucus in the stomach, much more than what is needed, then this mucus will pass out in the stool ultimately. The mucus will pass out in the stool. So if there's increased mucus production, and then this mucus is lost in stool. It goes out in the stool. So now what will happen? Because of a lot of mucus production and this mucus is going out in the stool, what is mucus? Mucus is nothing but protein. What is mucus? Mucus is nothing but protein. So they are losing so much of their protein in the stool. So they are losing so much of mucus in the stool. They are producing so much protein and they are losing so much protein. So this leads to hypoproteinemia. So now these people, they have hypoproteinemia. So they lose lot of their protein in the blood decreases. There is hypoproteinemia, and this hypoproteinemia now it results in, number one, hypoproteinemia results in edema. They develop. So if the amount of proteins in the blood decreases, especially hypoalbuminemia, they lose albumin. Hypoalbuminemia. So they lose of all the proteins, one of the proteins that is lost in the stool is albumin. So now if they lose their proteins in the blood, the protein levels, albumin level falls down. And you know, very important function of albumin in the blood is it maintains the plasma colloid osmotic pressure. Or in other words, albumin retains water in the blood. So if albumin level in the blood falls down, water will go out of the blood vessels into the extracellular tissue, into the extracellular or extravascular space, into the extravascular space. So that results in edema. So they develop edema. So these patients develop edema. So they develop edema. Also they develop weight loss. So they are losing so much of proteins. So they have weight loss also. Okay. Second important feature is there is hyperplasia of foveolar epithelial cells, 1, and 2 now. So there is hyperplasia of foveolar epithelial cells. So the lining epithelium becomes so much. The underlying gastric glands, in the lamina propria, you have those gastric glands which have the chief cells and the parietal cells. Yes. So those gastric glands undergo atrophy. So there is atrophy. So the epithelium becomes so much that the underlying glands undergo atrophy. So there is atrophy of these gastric glands. So in the gastric glands contain parietal cells. So there is decreased parietal cells. So not just parietal, even the chief cells decrease. But when the parietal cells decrease, this leads to decreased hydrochloric acid production, decreased HCl production. So HCl, so parietal cells also undergo atrophy. So there is decreased parietal cells or parietal cell atrophy, and as a result there is decreased acid production. So decreased acid production is there. Okay, clinical features. Now how does the patient present? Clinical features. Number 1, patient has abdominal pain. 1. 2, nausea. They are producing lots and lots of mucus, nausea, vomiting. So nausea, vomiting, abdominal pain, anorexia, weight loss, and sometimes, you know, they can even develop blood in the stools. So occult blood in stools, because they can develop erosions in the stomach, which can cause, yes, Adesh, absolutely, pressure atrophy. So the lining epithelium, the cells, foveolar epithelial cells become so much that they cause, under the foveolar epithelial cells are gastric glands, so they cause pressure atrophy of the gastric glands. Okay, and occult blood in the stool. Gross, if you look at stomach, what will you see? Normally, you know, the mucosa of the stomach, normal mucosa, it is thrown into folds. The mucosa is thrown into folds, and we call these folds rugae. So stomach mein jo mucosal folds are, they are called rugae, R-U-G-A-E. So now what do you have? These rugae, they appear very hypertrophied. So you have giant rugal folds. So what do you see? You see giant rugal folds. What are rugal folds? Mucosal folds, or in other words, you see giant mucosal folds. Mucosal folds. And you know, these giant, because of these giants mucosal folds, giant rugal folds or giant mucosal folds, you know, the stomach looks like brain gyri. So the stomach looks like brain gyri. So the stomach looks like brain gyri. So it looks like this gyri of the brain. So we'll just see a picture. This looks like gyri of the brain. So that is Menetrius disease. So that is Menetrius disease. Okay, let us see a picture now. Okay, so this is the question. This is the history of Menetrius disease. A 44-year-old male presents to his primary physician complaining of vague abdominal pain, nausea, and vomiting. He reports that his shoes no longer seem to fit, and wonders if he might have venous insufficiency. Okay, so his shoes no longer seem to fit. So what does that tell you? Shoes no longer seem to fit means he has developed edema in his feet, pedal edema. So there is edema in the feet. Because of the edema in the feet, his shoes are not fitting, and he has this vague abdominal pain, nausea, and vomiting. And hemoccult blood in the stool is positive. So occult blood in the stool is positive. So now this is the picture. This is normal gastric mucosa as seen by endoscopy, and now these are giant rugal folds. Giant rugal folds. So this is the picture of Menetrius disease. Menetrius disease. So Sridevi, I told you why edema. Why edema? You people know already. Edema because lot of mucus is being produced. Mucus is nothing but proteins. Proteins are being lost in the stool. So in the blood, protein level is decreasing. There is hypoproteinemia. Albumin level. Albumin is the protein that is also being lost in the mucus. So there is hypoalbuminemia, and hypoalbuminemia is leading to edema. Albumin in the blood is responsible for maintaining plasma colloid osmotic pressure. So if albumin in the blood decreases, water will go out from the blood vessel into the extravascular space and cause edema, which happens here. Okay, so that is Menetrius disease. Then next entity in stomach, next is gastric tumors of the stomach. Okay, tumors of stomach. Okay, you are answering. All right. Okay, edema. Okay. So which are the tumors, malignant tumors of the stomach? Most common, so tumors, malignant tumors of stomach, names, let us see. Malignant, most common malignant tumor of the stomach is gastric adenocarcinoma. Gastric adenocarcinoma. So, you know, adenocarcinoma is an epithelial tumor arising from, malignant epithelial tumor arising from glands. Okay, second malignant tumor that can arise in the stomach is a lymphoma. So, stomach can have lymphomas. Third malignant tumor is what we call GIST, gastrointestinal stromal tumor, which we call GIST. And fourth malignant tumor that can arise in the stomach, which is rare, is carcinoid tumor. Carcinoid tumor is rare. So four main malignancies of the stomach are, most common malignancy of stomach is gastric adenocarcinoma. Second, lymphoma is a malignant tumor arising from the lymphoid cells. Then gastrointestinal stromal tumor, and third is carcinoid tumor. Okay, now I'm going to talk about this tumor, that is gastric adenocarcinoma. Okay, let us look at gastric adenocarcinoma. Gastric adenocarcinoma. Okay, gastric adenocarcinomas. This is the most common Most common malignancy of stomach. So we already know that most common malignant tumor of stomach, as I have already written, of stomach is gastric adenocarcinoma. And gastric adenocarcinoma, microscopically, it is divided into two types. So gastric adenocarcinomas are of two types. They are of two types, intestinal type. So it's of two types, intestinal type and diffuse type. So it is of two types, gastric adenocarcinomas are of two types, intestinal type and diffuse type. Okay, we'll see what they mean. Okay, intestinal type, risk factors. Risk factors for intestinal type are very important is H. pylori. H. pylori infection. H. pylori infection 1. 2. Nitrosamines in diet. Nitrosamines. So if you remember in neoplasia chapter, in carcinogens, we had talked about nitrosamines leading to gastric cancer. So nitrosamines, you know, they are found in smoked foods. Third, tobacco. Fourth, so tobacco is associated, tobacco smoking. Okay, then achlorohydria. Achlorohydria, as you see in autoimmune gastritis, we have achlorohydria, and then any form of chronic gastritis, because you know chronic gastritis will lead to gastric atrophy, and that can predispose to intestinal metaplasia and gastric cancer. And you know these intestinal types, location, where are they located? They are located, generally located common on lesser curvature. Common on lesser curvature of stomach. So located on common on lesser curvature of stomach, and usually gross. How do they present? Gross, how do you see? It is usually an ulcer. It presents as it is an ulcer with raised margins. Presents as an ulcer with raised margins. And microscopy in intestinal type, what do you see? In intestinal type, so it is usually an ulcer with raised margin. Microscopically, you see malignant glands. So what do you see? You see malignant glands. So it presents the stomach is infiltrated, the wall of the stomach is infiltrated by malignant glands. Okay, second is the diffuse type. Now diffuse type is not associated with H. pylori. Okay, it may be associated with other factors, no association with H. pylori. Can be associated with these factors. That is nitrosamines, tobacco, achlorohydria, chronic gastritis, but not associated with H. pylori. Okay, location can be no specific type of location here. Okay, now gross, how does this present? Diffuse type, you know, in diffuse type, the wall of the stomach, full thickness wall of the stomach is markedly thickened and leather-like. So gross, if you see, so it can be same as lesser curvature or anywhere. Gross wall of stomach is markedly thickened and leather-like. So wall of stomach is markedly thickened and leather-like, and this is called leather bottle stomach, or another name, or linitis plastica. So this is called leather bottle stomach. So what do you call this? You call this leather bottle stomach or linitis plastica. Okay, and very important, now on microscopy, what do we see? In diffuse type. In diffuse type, you don't see malignant glands. No, it's gland formation is not there. So in diffuse type, what do we see? In diffuse type, we see signet ring cells. So you see signet ring, malignant cells are signet ring cells. So what do you see? You see signet ring cells, no gland formation. Okay, now signet ring cells are malignant cells. How do they look like? What is the appearance of a signet ring cell? You know, a ring with a big stone in it. If you wear a ring with a big stone in it, So what do you see in a signet ring cell? In a signet ring cell, the nucleus is pushed to one side like this. Nucleus is stretched and it is pushed to one side, and there is mucin. What pushes the nucleus to one side? A blob of mucin in the cell. So malignant cell has, so this is mucin, and this is the nucleus of the cell pushed to one side. So this is now what you call as a, so the cell looks like a signet ring. So this is what you call as signet ring cell. Okay, so this is gastric cancer, the two histological types, intestinal and diffuse. Okay, now very important in gastric cancer is depth of invasion. So very important prognostic factor in gastric cancer is how much deep into the stomach the tumor has gone. So based on depth of invasion, so whether it is intestinal or diffuse type, based on depth of invasion, gastric cancer is, okay, Abhinav, yes, I will repeat. Just let me finish this. So based on depth of invasion, gastric cancer is divided into early gastric cancer, early gastric CA, and advanced gastric CA. Advanced gastric CA. So based on depth of invasion, why do we take depth of invasion? Because depth of invasion is a very important prognostic factor. If the tumor has gone really deep, it will have a poor prognosis. If the tumor is comparatively superficial, it will have a better prognosis. So depth of invasion is an important prognostic factor in gastric cancer. So based on depth of invasion, tumors, gastric cancers are divided into early and advanced. What is early gastric cancer? What is early gastric cancer? Early gastric cancer is limited to mucosa and submucosa. So cancer limited to mucosa and submucosa and submucosa. And advanced gastric cancer is cancer goes beyond submucosa. Beyond submucosa. So it goes beyond the submucosa, it goes into the muscularis propria, it goes into the serosa, and can even go out of the stomach. So that is advanced gastric cancer. So early gastric cancers, they carry a good prognosis. So knowing this becomes important because early gastric cancers have a good prognosis. Advanced gastric cancers have a poor prognosis. So advanced gastric CA has a poor prognosis. Okay. Now gastric cancer, you know, it is an aggressive tumor and they can metastasis. So where can they go? So metastasis to lymph nodes. So gastric cancer can metastasize to lymph nodes, and metastasis to can produce mets to liver. So metastasis to lymph nodes and mets to livers. Okay. Now clinical features. Okay. Now Abhinav has asked me, can you repeat the difference once again? Okay. So now histologically, gastric adenocarcinomas are divided into two types, intestinal type and diffuse type. Very important risk factors for intestinal type is H. pylori infection. Others are nitrosamines, tobacco, achlorohydria, and chronic gastritis. In diffuse type, risk factor, remember, H. pylori is not associated with diffuse type of gastric cancer. So no association with H. pylori. All the other factors, nitrosamines, tobacco, achlorohydria, chronic gastritis, they can cause diffuse type of gastric cancer, but diffuse type has no association with H. pylori. Okay. Now, intestinal type is commonly located on the lesser curvature and it presents as an ulcer with raised margins. Diffuse type can involve any part of the stomach, and in diffuse type, what do you see? The wall of the stomach is diffusely thickened, markedly thickened, and leather-like, and hence it is called leather bottle stomach or Linitis plastica. Then in intestinal type, if you do a microscopic examination of this ulcer, malignant ulcer, what will you see? You will see malignant glands. Whereas in diffuse type, if you do a biopsy, you will find the malignant cells are signet ring cells. No gland formation is seen here. So what is a signet ring cell? It has a big mucin, blob of mucin in its cytoplasm that pushes the nucleus also to one side. Okay, yes, Adesh, that's a very good question. You know, what I did not tell was, what I thought would be too much for you is, the type of mutation that you get. So in diffuse type, no gland formation is seen, because in diffuse type, in diffuse type of gastric cancer, so if you look at this diffuse type, why do signet ring cells form? Because there is mutation in CDH1 gene, a gene called CDH1. And this CDH1 gene, it produces E-cadherin. E-cadherin. What does it produce? E-cadherin. So when there's mutation in CDH1 gene, which we see in diffuse type, there is no E-cadherin. E-cadherin. Okay. Now, what is the function of this E-cadherin? What is the function of this? So, in diffuse type, there are CDH1 mutations, and CDH1 mutations, if they occur, no E-cadherin is produced. Normal CDH1 gene encodes for E-cadherin, so no CDH1 gene, no E-cadherin. Now, what is the function of E-cadherin? E-cadherin holds the cells together. It holds all these cells together. So, why are glands formed in intestinal type? Because there is E-cadherin. It is holding the cells together and helping to form glands. In diffuse type, there is no E-cadherin. So the cells, the E stands for epithelial cadherin, and cadherins bind the cells together. They are adhesion molecules. They make the cells adhere together. So now there is no E cadherin, there is no adhesion molecules. So single malignant cells infiltrate into the wall of stomach, and the wall of stomach becomes very thick and leather-like. So that is why, because of loss of E cadherin, there is no gland formation in diffuse type. There is no gland formation in diffuse type. Okay. Then based on depth of invasion, you divide gastric cancer into early and advanced. Early gastric cancer is limited to mucosa and submucosa and carries a good prognosis. Advanced gastric cancer goes beyond the submucosa. Okay, now where all do they produce metastasis, gastric cancer? They can go to the lymph nodes and metastasize to the liver. Okay, clinical features. Clinical features, patients usually present late. Late in the disease, late in the course of the disease. They usually present late, and they give history of weight loss. 1, 2, early satiety. What does early satiety means? थोड़ा सा खाना खाया और एकदम पेट भर गया. So they eat little and they feel full. They eat little and they feel very full. Okay, so early satiety. And then they can also have, in some cases, patients present with paraneoplastic syndrome. Paraneoplastic syndromes. So again, in the chapter of neoplasia, I have told you both these syndromes. So which are the two paraneoplastic syndromes which the patients with gastric cancer can present? Number 1, acanthosis nigricans. Acanthosis nigricans. So gastric cancer patients can present with acanthosis nigricans. What is acanthosis nigricans? Especially in the neck region, the skin becomes very thick and dark pigmented. That is acanthosis nigricans. And second, lesser trilate sign. LESER, lesser trilate, TRELAT, trilate sign. So the second is lesser trilate sign. Yes, okay. So lesser trilate sign. Lesser trilate sign, what is lesser trilate sign? Lesser trilate sign is they have eruption of seborrheic keratosis. So they have sudden eruption of seborrheic keratosis. So on the skin, they develop seborrheic keratosis, eruption of seborrheic keratosis. So they develop eruption of, yes, Sridevi, it is a signet ring cell carcinoma. Diffuse carcinoma, gastric cancer is a signet ring carcinoma. So they develop eruptions of seborrheic keratosis. So I'll show you a picture. Okay, then in gastric cancer, you also have to know, patients with gastric cancer, other important features, gastric cancer can metastasize to the lymph nodes. Okay, it metastasizes to the local regional lymph nodes, which are there along the lesser and the greater curvature. They are regional lymph nodes. Plus, in addition to regional lymph nodes, gastric cancer can metastasize to left supraclavicular lymph node. So the lymph nodes it can metastasize to are, number 1, first you have something called Virchow's node. Virchow node, VIRCHOW, Virchow node. What is Virchow node? Metastasis to left supraclavicular lymph node. So gastric cancer producing metastasis to left supraclavicular lymph node. Metastasis to left supraclavicular lymph node. Second, okay, so this is lymph node, so they can metastasize to, okay, I'm rubbing this left supraclavicular lymph node. Second, you know, in females with gastric cancer, metastasis can be produced in bilateral ovaries. So bilateral ovaries can develop metastasis. This is called Krukenberg tumor. K-R-U-K-E-N, Krukenberg tumor. What is Krukenberg tumor? Krukenberg tumor is bilateral metastasis to ovaries. Metastasis to ovaries. So the tumor is going to ovaries, and you know, you will see these signet ring cells on those mucin producing cells in the ovaries. So the ovaries will show signet ring cells, or there will be abundant mucin secretion. So there will be glands. It can be intestinal or diffuse type, which can go to the ovaries. So if diffuse type goes, you will see signet ring cells. If intestinal type goes, you will see glands with abundant mucin. So abundant mucin production will be seen. This is Krukenberg. Third, you know, gastric cancer can produce metastasis around the umbilicus, in the subcutaneous tissue. So in the subcutaneous tissue around the umbilicus, metastatic deposits can occur. These are called Sister Mary Joseph nodule. Sister Mary Joseph nodule. Sister Mary Joseph nodule. What is Mary Joseph nodule? Subcutaneous periumbilical metastasis. So subcutaneous periumbilical metastasis. Subcutaneous periumbilical metastasis. And last is there is something called Blummer shelf. B-L-U-M-E-R. Blummer shelf. Again, in females, you know, Blummer shelf means metastasis in the rectouterine pouch, that is pouch of Douglas. So metastasis in rectouterine pouch. What is rectouterine pouch? Pouch of Douglas. So metastasis in the rectouterine pouch, that is the pouch of Douglas. So they can produce metastasis and all that. Okay, Ayush, you've written Trousseau's sign. It is Trousseau's, T-R-O-U-S-S-E-A-U-S, Trousseau's sign. Trousseau's sign, again, I have already told you what that is in the chapter of neoplasia. That is migratory thrombophlebitis. Migratory thrombophlebitis, which is seen in pancreatic cancer, may be seen in gastric cancer as well. Okay, and yes, Sridevi, what you have written is correct. What you have mentioned in your big note about Virchow's node and metastasis in the abdomen, that's correct. Okay. Then now, so this finishes with gastric cancer. Now, next very important topic that we have to cover in stomach is peptic ulcers. Peptic ulcers. Okay. What is a peptic ulcer? Okay. So what are peptic? Okay. Let us first see a picture of this. Okay. Okay, now look at this picture. Look at this question. Okay. A 70-year-old female presents to your office with nausea, vomiting, and 3 months of weight loss. On physical examination, you observe the findings seen in figure A. So look at figure A. Look at the finding. You suspect adenocarcinoma and you immediately order a biopsy to ascertain the extent of metastatic disease. In which of the following organs would you observe the primary tumor with abundant mucus and signet cells on biopsy if metastatic disease was present? So now the picture B, these are signet ring cells. Look at picture B. Picture B is showing you all these cells in this picture are signet ring cells. Okay, and look at this third picture. You can see what is this? This is lesser trilate. Trillet sign. What is lesser trillet sign? Sudden eruption of seborrheic keratosis. So figure A, what is it knowing? This is periumbilical nodule. So what are these? These are sister Mary Joseph nodules. Sister Mary Joseph nodules. So what is the answer to this question? So signet ring cell, answer is number 1. Yes, absolutely, Sridevi, around. So the answer is stomach here. So answer is stomach. So you can see lesser trillet sign here. You can see Sister Mary Joseph nodule, that is periumbilical subcutaneous tumor deposits, and microscopy of how signet ring cells look like in diffuse type. So answer is 1, that is stomach. Okay. So now let us come to peptic ulcers. Again, this picture you already know. Okay. Now Pooja, answer is 1, that is stomach, not ovary. Here you are asked, in which of the following organs would you observe primary tumor? So you have to tell the primary. Okay. So primary is in the stomach. It can go to the ovary, yes, producing Krukenberg tumor. It can produce Sister Mary Joseph nodules. It can produce Blummer shelf. It can produce Virchow's node. But where is the primary? So you are asked, where is the primary tumor? Primary tumor is, your question is primary tumor is in the stomach. So yes, it can go to the ovary, produce Krukenberg, but then that will be metastasis, not a primary tumor. Okay. Okay. Now let us come to peptic ulcer. So again, the same figure which we saw, which is the normal defense mechanism in the stomach. Again, I am showing because this is important. Normal defenses, forces that damage the gastric mucosa are gastric acidity, that is HCl, and peptic enzymes. And defense mechanisms are, what produces the defense is, number 1, you can see this is the mucus layer on top. So surface mucus secretion is important. Bicarbonate secretion in the mucus. Yes, Adesh, absolutely. Answer is A. Then mucosal blood flow, epithelial barrier function, epithelial regenerative capacity, and elaboration of prostaglandins. These are all protective. So they are all protective. Okay. Now, peptic ulcers are ulcers that are produced. Peptic ulcers can occur in the stomach. Peptic ulcers can occur in the duodenum, and sometimes even in lower esophagus you can have peptic ulcers. And peptic ulcers are produced because either the mucosa gets injured. Injury can be due to H. pylori, NSAIDs, tobacco, alcohol, gastric hyperacidity, or gastroduodenal reflux. Or ulcers or erosions can also be produced due to impaired defenses like ischemia, shock, and NSAIDs. All can produce ulcers in the stomach. So you can look at this ulcer now. Ulcer in the stomach. What are you seeing in this ulcer? So what is an ulcer? Ulcer is a defect in the mucosa. It's a defect in the mucosa. So in the ulcer, so you can see this is an ulcer here, and at the base of the ulcer, what are you seeing? Necrotic debris. So what are you seeing at the base of the ulcer? Necrotic debris. Beneath the necrotic debris, you have non-specific acute inflammation. Then below the acute inflammation, you have granulation tissue, and below the granulation tissue, you have fibrosis. So this is a peptic ulcer, the various layers in the ulcer. So big ulcer, big defect. At the base, you have N, necrotic debris, I, non-specific inflammation, G, below the inflammation is granulation tissue, NIGS. And below the granulation tissue, there is fibrosis. Why are ulcers, peptic ulcers, where are the peptic ulcers located? Where can the peptic ulcers be located? Peptic ulcers can be in the stomach, in the duodenum, or even in the lower esophagus they can occur. Why do peptic ulcers occur? So they are defect or ulcers, defect in the mucosa. Why do they occur? Because of injury to the gastric mucosa, which can be due to H. pylori, NSAID, tobacco, alcohol, gastric hyperacidity, or duodenogastric reflux. Or if the defenses of the stomach are impaired, like in ischemia, shock, or NSAIDs, that produces ulcers in the stomach. Okay. Okay. Now this is, so you can see these peptic ulcers. You can see the ulcer here. If peptic ulcer occurs in the stomach, you call it gastric ulcer. If peptic ulcer occurs in the duodenum, so this is first type stomach, 2, they can occur in the duodenum, you call them duodenal ulcers. If they occur in the lower esophagus, you call them esophageal ulcers. So location of this ulcer. Now this, see this, this is a gastric ulcer here. So this is in the stomach, gastric ulcer. Okay, this is another gastric ulcer here which is oozing. So these are gastric ulcers. Endoscopy of the stomach is showing these two areas of, both these are ulcers. So oozing by gastric ulcer observed in distal antrum. Oozing has stopped after injection. So this is the ulcer. So this is first picture is ulcerated area is oozing blood. So you can only see blood. In the second area, the blood has been cleared. Oozing has stopped. So you can make out the ulcer. So this is a gastric ulcer. This is another picture of gastric ulcer. So this is the area of the ulceration. This is another picture of ulcer. Okay. Now let's come to this peptic ulcers. Okay, so now peptic ulcer, what is a peptic ulcer? Defect in the mucosal. So where does peptic ulcer occur? It is a defect in the mucosal lining of stomach. So they can occur in the stomach. When they occur in the stomach, you call them gastric ulcers, duodenum, or even though less common, sometimes lower esophagus. So sometimes in the lower esophagus, and it results from imbalance between gastric defense mechanism and damaging factors, and result from, you already know this, result from imbalance. So they result from imbalance between, imbalance between gastric defense mechanism and damaging factors. So we already saw in the picture, damaging factors were NSAIDs, H. pylori, alcohol, gastroduodenal reflux, and all those were the damaging factors. And impaired between gastric defense mechanisms get impaired in case of ischemia and shock. So they result from imbalance between gastric defense mechanisms and damaging factors. So if damaging factors become more and if the defense mechanisms become weak, ulcers will occur. Okay. Now ulcers, two main categories of ulcers are the ones that occur in the stomach, they are gastric ulcers. Ones that occur in the duodenum, they are duodenal ulcers. So you have to compare these two. So number one, gastric ulcers. Ulcers occurring in the esophagus are very uncommon. So gastric ulcers are less common, and duodenal ulcers. Okay, where do the gastric ulcers occur? So, okay, first let us see the features. Okay, pain. In both gastric and duodenal ulcers, patients complain of pain. Okay, in case of gastric ulcer, G for gastric, G for greater. So the pain is greater with meals. So pain greater with meals. So if the patient eats food, the pain becomes more. So what happens, so the pain is exacerbated by food intake. So greater with meals means pain is exacerbated by food intake. So patient eats less food. So they eat less, and this leads to weight loss. In contrast, in duodenal ulcer, the pain is decreased with meals. So pain is increased with meals. So I write the word increased or greater with meals. So increased or greater with meals, and in case of duodenal ulcer, pain is decreased with meals. So eating food will reduce the patient's pain, and as a result, the patient will go on eating more to reduce his pain. So this will cause weight gain. This causes weight gain. Okay, second, gastric ulcers and duodenal ulcers both are associated with H. pylori infection. In case of gastric ulcers, H. pylori infection in approximately 70% cases. Whereas in case of duodenal ulcers, H. pylori infection in approximately 90% cases. Okay, in case of, once again, in a patient with gastric ulcer, when they eat their meals, their pain becomes more. So, they avoid eating food. So if they eat less, they will lose weight. So there will be weight loss. In case of duodenal ulcer, when they eat food, their pain decreases. So soothing effect, food has a soothing effect. So they tend to eat more and more and hence end up with weight gain. Okay. Then H. pylori infection can occur in both gastric and duodenal ulcers. In case of gastric ulcers, H. pylori infection is seen in 70% cases, in duodenal ulcers 90%. Then mechanism. What is the mechanism of gastric ulcers? In case of gastric ulcers, there is decreased mucosal defense mechanism against gastric acids. So we saw there is decreased mucosal defense mechanisms. So decreased mucosal defense mechanisms are responsible for causing gastric ulcers. Whereas in case of duodenal ulcers, both the factors, decreased mucosal defense and also increased gastric acid production. Both the factors operate. So increased gastric acid production. Okay. Other than this, other causes for gastric ulcers are NSAIDs. They are associated with NSAIDs and also with tobacco and ischemia and so many more. NSAID is very, very important. And duodenal ulcers may be associated with Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. Okay, now here I mentioned the mechanism, decreased mucosal defense mechanisms. So in decreased mucosal defense mechanisms, so there are many causes as we have seen. So all those causes will come here. So if you see this picture once again, decreased mucosal defense mechanisms are seen in ischemia, shock and SAIDs. Then increased, second is you have H. pylori infection associated with both gastric and duodenal. Then other factors that cause gastric, hyperacidity. So one of the causes for gastric hyperacidity is, which we see is Zollinger-Ellison syndrome. In Zollinger-Ellison syndrome, there is this hypertrophy of, there is increased gastrin production. So increased gastrin production means increased HCl production. So gastrin will stimulate more production of hydrochloric acid and that will cause duodenal ulcers in the duodenum. So other causes are these. Okay, risk of cancer, very important, risk of CA, risk of cancer. Gastric ulcers may turn malignant. So risk of cancer is increased, whereas duodenal ulcers, they are generally benign. So duodenal ulcers, they are generally benign. So others, what else should you do in case of gastric ulcers? Because there is a risk of malignancy, do biopsy from margin of ulcer to rule out malignancy. So you should do a biopsy because it's associated with increased risk of cancer. So do a biopsy from the margin to rule out malignancy. In contrast, in duodenal ulcers, so they are located in the duodenum. So when you do a biopsy of the ulcer, what will you see? You will see hypertrophy of Brunner's glands. So you know Brunner's glands are located in the duodenum. So you will see hypertrophy of Brunner glands. So you will see hypertrophy of the Brunner glands. Okay, now what are the complications? What are the complications of gastric and duodenal ulcers? So what are the complications of ulcers? So whether gastric or duodenal, what are the complications? First complication is hemorrhage or bleeding. First complication is bleeding or hemorrhage. Okay. Now gastric ulcers and duodenal ulcers both can bleed. So both can produce this complication, that is duodenal. So both gastric can also bleed. So complication with both is gastric ulcers can also bleed. Duodenal ulcers can also bleed. Okay. So both the ulcers So both. Okay. Okay, now coming to complications. One of the complications is bleeding. Both gastric and duodenal ulcers can bleed. Both gastric and duodenal ulcers can bleed. In case of duodenal ulcers, bleeding is more common with the ulcers located on the, in the duodenum you have the anterior and the posterior wall. So posterior ulcers, wall ulcers are more likely to bleed than the anterior. So posterior wall ulcers are more likely to bleed than the anterior, and bleeding is the most common complication. Bleeding is the most common complication. And sometimes, these gastric ulcers can rupture. So they can, and can bleed, and bleeding can lead to death also. Second, obstruction. Ulcers can cause obstruction. Okay, now which ulcer cause obstruction? The ulcers which are located in the pylorus or in the duodenum. So pylorus, ulcers in the pylorus. Okay. Pylorus, ulcers located in the pylorus or duodenum. Duodenal ulcers are more likely to cause obstruction. Okay, then third is perforation. Perforation. Okay, perforation now is more common with duodenal ulcers. With duodenal ulcers, and again, now anterior wall more common than posterior. So the anterior wall ulcers will perforate more commonly than the posterior. Posterior wall duodenal ulcers are more likely to bleed. Anterior wall duodenal ulcers are more likely to perforate. And when an ulcer perforates, air appears under the diaphragm. So free air under the diaphragm. So this produces free air under the diaphragm, and patient can have referred pain in the shoulder because via the phrenic nerve. So free air under the diaphragm, and also free air under the diaphragm on X-ray, and referred pain in shoulder. Referred pain in shoulder, or referred pain to shoulder via phrenic nerve. Phrenic nerve, due to irritation of the phrenic nerve. So this is about the what you call gastric and the duodenal ulcers. So this finishes with the gastric and the duodenal ulcers. Okay. So now let me show you a question. Okay. Okay, this question you already know. Okay, let us look at this question. This answer you already know. 45-year-old male alcoholic with history of portal hypertension presents with vomiting of blood, that is hematemesis, and hypotension. He denies any history of vomiting non-blood material or retching prior to blood vomiting. During workup, he dies suddenly. Which of the following histological changes is most likely to be seen in the biopsy specimen taken from his esophagus? So this we have already covered. So what is the answer to this question? Write down the answer. What is the answer to this question? What is the answer to this question? Okay, answer is dilated blood vessels in the submucosa. What are these? These are esophageal varices. Esophageal varices. So very characteristic history. Okay, so those bleeding there will be hematomesis. Bleeding will come in the vomiting and will also go out in the stool. And yes, absolutely, they will have what you call as melena. They will develop melena. Okay, so these are esophageal varices. So he's an alcoholic patient with portal hypertension. Portal hypertension is producing esophageal varices. Okay. So answer is dilated vessels in the submucosa of esophagus. Yes, Adesh is right. This is esophageal varices. Okay, then next question number 10. Okay, Sridevi is also right. A 49-year-old woman taking ibuprofen for increasing joint pain in her hands presents with increasing pain in her mid-sternal area. Gastroscopy shows multiple scattered punctate hemorrhagic areas in the gastric mucosa. So gastric mucosa में punctate scattered hemorrhagic areas. Biopsy from one of the hemorrhagic lesion reveals mucosal erosions with edema and hemorrhage. No mucosal ulceration is seen. Which of the following is the most common diagnosis? So there are erosions, but not ulcers. So patient has erosions. That means patient has erosions but not ulcers, and she is taking ibuprofen. So what is the answer to this question? So what is the answer to this question? So this is, answer is B. B, that is, this is acute erosive gastritis. So answer is B. Yes, Ayush, it's right. It's acute erosive gastritis. These are not peptic ulcers. This is not chronic gastritis. Okay, so because erosions are being produced. In peptic ulcer disease, it's not an erosion. It is a proper ulcer. Erosion is only when the lining epithelium part is denuded. Whereas if ulcer is when it goes deep. So not just the epithelium, but it goes up to the, as you saw in this picture, till where is the ulcer going? It is going up till the, okay, not this, wait, I'll just show you the picture once again. So look at the picture. Okay, so this is the ulcer. It is involving the mucosa and it is full thickness of the mucosa, and it is extending up to the full thickness of the mucosa is getting not just the lining epithelium, but the entire, yes, Pooja, answer is B, entire epithelium, and it is going even into the submucosa as well. Okay, so that is the ulcer. Okay, no, we have to go back to the question. So answer to this is acute erosive gastritis. Okay, we have seen this question. Okay, now next is we start with the intestine. Okay, do you want 10 minutes break? Shall we take 10 minutes break and then I start with intestine? Okay, it is 8:33. 8:45. Break till 8:45. Okay, break till 8:45, 10 minutes. Okay, so let's come back now. Okay, now Adesh, you had asked me why, okay, you asked me why in duodenal ulcers, your question was why pain decreases in duodenal ulcer and why pain is increased with meals in case of gastric ulcer. Okay, now here remember what is the cause for duodenal ulcer? In duodenal ulcer, there were two causes. One, decreased mucosal protection. Second, increased gastric acid secretion. Gastric acid secretion. So, in duodenal ulcer, when patient eats food, food reduces the acidity. It acts as a buffer, it reduces the acidity, and that is why the pain is relieved with food. Whereas in case of gastric ulcers, what is the main mechanism for ulcer formation? Main mechanism is decreased mucosal protection, decreased gastric defense mechanism. It's not increased acid usually, it is the decreased mucosal defense mechanisms. So here now eating food will not help because it is not related to hyperacidity. So in case of duodenal ulcers, because there is hyperacidity, eating food acts as a buffer and it reduces the acidity and therefore the relief from pain. Okay, now let us come to small intestine. Okay, small intestine. Now in small intestine, I'll talk about malabsorption. Malabsorption syndromes. Causes of malabsorption. Okay, now malabsorption syndromes. Okay, what is malabsorption? Malabsorption means the nutrients from the food are not getting absorbed. So basically inability to absorb the nutrients from the food. So what is malabsorption? Inability to absorb nutrients from the food. Nutrients from food. So whatever food we have eaten, we are unable to absorb nutrients from that. And so that is called as malabsorption. And what does malabsorption cause? Clinical features. What does malabsorption cause? Okay, malabsorption can cause diarrhea. Patient will now have diarrhea. So they can have diarrhea, steatorrhea. Steatorrhea. So I hope your answer is clear to you, Adesh. Okay, so diarrhea, steatorrhea. Third, if nutrients are not getting absorbed, there will be weakness, weight loss, and also patient develops vitamin and mineral deficiencies because even in some vitamins and minerals may not get absorbed. So vitamin and mineral deficiencies. Vitamin and mineral deficiencies. And so vitamin and mineral deficient. Patient may develop vitamin and mineral deficiencies also. So steatorrhea word means passage of fat in the stool. So you can screen for fetal fat. So one of the investigations that you can do in malabsorption, which I'll write later, is you screen for fetal fat by if you stain the fecal fat with a stain called Sudan black. Sudan black is a fat stain. So or you can do a 72 hours fecal fat test. So fecal fat, so fat in the stools, fecal fat. How can you demonstrate fecal fat? Number one, you can do a screen for fecal fat by Sudan black stain. So Sudan black stain, or you can do 72 hours fecal fat test. This is of course more sensitive. This is more sensitive. Okay, now let's see causes of malabsorption, which I am going to talk about. Causes of malabsorption that I am going to discuss today are: number one, celiac disease. So one is celiac disease. Second cause of malabsorption is lactose intolerance. Third is pancreatic insufficiency. Fourth I'll talk about is, with celiac disease, I will cover tropical sprue. And fifth is Whipple's disease. Whipple's disease. So these are the 5 important causes of malabsorption which I am going to cover. Okay, now first I'll start with celiac and then go to tropical sprue and then come to others. So first let us come to celiac disease. Okay, celiac disease. Okay, Akanksha and Adesh, what do you mean by BS? You've written BS on the chat. What do you mean by that? Okay, so celiac disease. What is celiac disease? Celiac disease is also called gluten sensitive enteropathy. So celiac disease is also called gluten sensitive. Am I audible and visible to all of you? Adesh and Akanksha and Sridevi and Abhinav, Yuthika, am I audible? Okay, they mean black screen. All right. Akanksha and Adesh, am I audible and visible now or still the screen, your screen is black? What about Adesh? Abhay, okay. So I'm audible to all of you? Okay, I understood. Abhinav, black screen mnemonic. Okay, BS is black screen. Okay, good way of. Okay, Adesh, you had asked me a question. Okay, now visible. So you missed all the part. Adesh, you had asked me about why you had written on the chat why in duodenal ulcer the pain decreases with meals and in gastric ulcer the pain increases with meals. I had given an explanation for that. Did you hear the explanation? Okay, so I'll just tell once again for benefit of all of you. In case of, I discussed before break, I talked about duodenal and gastric ulcers. I told you mechanism in case of duodenal ulcer. What is the mechanism leading to ulcer formation? Mechanism is number one, mucosal defenses decrease, and number two, gastric acid secretion increases. Duodenal ulcers are due to increased gastric acid secretion and also due to decreased mucosal defenses. Both factors play a role. Now, if a person eats food, you know, what does food do? Food acts as a buffer and food decreases the gastric acidity. So it acts as a buffer, decreases gastric acidity, and therefore the patient feels better after eating food in case of duodenal ulcers. And in case of gastric ulcer is mainly due to decreased mucosal protection and not gastric hyperacidity. Therefore, when the patient eats food, there is more damage to the gastric mucosa. Okay, so Adesh, what were you asking about cancer then? I can't see your question. Okay. Okay, why increase risk of cancer? Okay. Okay, why increase risk of cancer? Okay, so okay, I'll see that also, and I'll tell you. Okay, now malabsorption. I started with malabsorption. Malabsorption. What is malabsorption? Inability to absorb nutrients from the food. Okay, Sridevi. Okay. Achha, what is malabsorption? Malabsorption is inability to absorb nutrients from the food. That is malabsorption. If a patient has malabsorption, clinical features are patient will have diarrhea, steatorrhea. Steatorrhea means fat in the stool. Then weakness, weight loss, and even vitamins and minerals are not getting absorbed. So vitamin and mineral deficiencies can be there. Now, if there is steatorrhea, you can look for fat in the stool. So one way of looking for fat in the stool is stain the stool with Sudan black bee stain. And second is do a 72 hours fecal fat test, which is more specific. Okay, then I've written down the causes. Causes of malabsorption, which I'm going to talk about now are number one, celiac disease, number two, lactose intolerance, three, pancreatic insufficiency, four, tropical sprue, and five, Whipple's disease. Okay, first is celiac disease. Celiac disease is also called gluten sensitive enteropathy. So what is celiac disease? It's also called gluten sensitive enteropathy, and celiac disease is an autoimmune disease. immune disease. So it's an autoimmune disease. It's also called gluten sensitive enteropathy. Okay, and what is celiac disease usually seen in is due to gluten sensitivity. So gluten is a protein. So gluten is found in, where do you find gluten? Gluten is found in, number one, wheat contains gluten, rye, oats, all these three, wheat, rye, oats, etc., and they contain gluten. And you know, this gluten, it contains a compound called gliadin, So gluten contains a compound called gliadin. So now what happens? What is the pathogenesis? Few lines on pathogenesis of gluten sensitive enteropathy. Or celiac disease. Now normally, you know, when we eat this gluten, when we eat wheat or barley or rye or oats, even barley, okay, wheat, barley, rye or oats, when we eat all these grains, in these grains, there is gluten. Gluten contains a compound called gliadin. And normally, you know, this gliadin, when it enters our intestine, this gliadin is broken down into deaminated gliadin. So pathogenesis, normally gliadin in diet or in food, it is broken down into deaminated gliadin and is metabolized. It is broken down into deaminated gliadin by an enzyme called tissue transglutaminase. Tissue transglutaminase. Okay, Ayush, from where do you want me to repeat? Ayush, which part should I repeat, Ayush? Okay, celiac disease, I am repeating celiac. Celiac disease is also called gluten sensitive enteropathy. Point number 2, celiac disease is an autoimmune disease. Celiac disease is called gluten sensitive. You know, gluten is found in wheat, rye, oats, barley. They contain gluten. And gluten contains a compound called gliadin. In gluten, we have a compound called gliadin. Now, you know, all of us, okay, so gluten contains a compound called gliadin. So normally in pathogenesis, what do we see? Normally, you know, when we eat this wheat, rye, barley or whatever, all of us, we are all right. So this gliadin in gluten is converted to deaminated gliadin by tissue transglutaminase. So we all have enzyme called tissue transglutaminase. This compound converts gliadin to deaminated gliadin, and this deaminated gliadin is then metabolized or it is absorbed. But in patients with celiac disease, what happens? So in patients with celiac disease, you know, celiac disease is associated with two HLA types. It is associated with two HLA types, HLA-DQ2 and HLA-DQ8. It is associated with two types, that is HLA-DQ2, two HLA types, DQ2 and DQ8. So now what happens? In patients with celiac, this deaminated gliadin acts like a foreign protein. It acts like a foreign protein, and HLA, these people, patients with celiac, they have HLA-DQ2 and DQ8. So this HLA-DQ2 and DQ8, so antigen presenting cells, you know, they have HLA-DQ2 and DQ8. With the help of HLA-DQ2 and DQ8, antigen presenting cells present this deaminated gliadin to T helper 1 cells. So they present it to T helper 1 cells, and T helper 1 cells now get activated. So T helper 1 cells activated. So this deaminated gliadin is presented by antigen presenting cells. Okay, so deaminated gliadin has HLA-DQ2 and DQ. Deaminated gliadin is presented by the antigen presenting cells. Patients with celiac usually have HLA-DQ2 and 8, and T helper 1 cells get activated. And these T helper 1 cells now produce a very important cytokine which you already know, that is interferon gamma. So they produce interferon gamma, and this interferon gamma, number one, it activates CD8 T cells. CD8 T cells. Interferon gamma activates CD8 T cells. CD8 T cells damage the intestinal mucosa. intestinal mucosa. So cytotoxic T cells, they damage the intestinal mucosa. Villi, there is loss of villi. So there is loss of villi. So obviously, if villi are lost, surface area for absorption is reduced. Surface area for absorption is reduced. So there's decreased surface area for absorption. And second, this interferon gamma. Okay, second is interferon. Another thing that interferon gamma does is interferon gamma also activates B cells. B cells. Interferon gamma also activates B cells, and these B cells now produce autoantibodies. They produce autoantibodies. Okay, the autoantibodies that we see in celiac disease are number one, so they are IgA class of antibodies. So they are anti-tissue transglutaminase antibodies. Tissue transglutaminase, anti-tissue transglutaminase, we also call them anti-TTG antibodies. Second is anti-gliadin antibodies, and third antibodies seen in patients with celiac are anti-endomysial antibodies. Anti-endomysial antibodies. So patients of celiac can have three types of autoantibodies, and these autoantibodies are of IgG class. These are anti-TTG antibodies, anti-gliadin antibodies, and anti-endomysial antibodies. So all these autoantibodies are produced. So now what is the HLA association? HLA association with celiac is HLA-DQ2 and DQ8. And it is an autoimmune disease. Which hypersensitivity? Celiac is a type 4 hypersensitivity reaction. And which are the cells that are activated? T helper 1 cells, which produce interferon gamma. Interferon gamma in turn activates CD8 T cells that damage the intestinal mucosa. Villi are lost. Surface area for absorption reduces. And second, interferon gamma activates B cells, which produce IgA class of autoantibodies. They are anti-TTG antibodies, anti-gliadin, and anti-endomysial antibodies. Okay, now associations of celiac disease. Associations. Number one, we have already seen celiac disease is associated with HLA-DQ2 and HLA-DQ8. Number one. Number two, celiac disease is seen in another association is dermatitis herpetiformis. Herpetiformis. So patients with celiac disease may also have dermatitis herpetiformis. Third association is type 1 diabetes. Type 1 diabetes mellitus. Then Sjogren's syndrome. Sjogren's syndrome and IgA nephropathy, which is a kidney disease. So IgA nephropathy. All these can have the associations of celiac disease. Okay, so these are the associations of celiac disease. Okay, now patients with complication. Patients with celiac disease can develop. So there are a lot of T cells, T helper 1 cells, CD8 T cells. So there are a lot of T cells in the mucosa. So patients with celiac disease these T cells can convert into a lymphoma. So they can have enteropathy associated complication, enteropathy associated T cell lymphoma. So patients of celiac disease can develop enteropathy associated T cell lymphoma. Okay, microscopy, what do you do? Microscopy for diagnosis of celiac, you do a biopsy from the small intestine. Okay, which part of intestine? So you do a biopsy is usually done from proximal intestinal biopsy. Proximal intestinal biopsy. So biopsy is usually done from duodenum, and we do it from second part of duodenum commonly, because that's easily accessible by endoscope. Because why do you do a proximal intestinal biopsy? Because it is the proximal part of intestine, that is the duodenum, which is exposed to maximum load of gluten. So, and D2 part of the duodenum is easily accessible by endoscope. So you do a D2 biopsy. So from the you do a duodenal biopsy, and now what do you see in microscopy? Number one, villus atrophy. Villi become atrophic. So there is villus atrophy, 1. 2, the villi become flat, crypts become deeper. So there is crypt, so villi become flat. Second, there is crypt hyperplasia. Crypt hyperplasia. Hyperplasia, that is crypts become deeper. Crypts become deeper. You know why this happens? Why crypt? So villi are lost. So when villi are lost, you know, in the crypts we have the stem cells. So since villi are lost, the stem cells in the crypt, they try to regenerate the villi. So they attempt, the stem cells in the crypt start multiplying because they want to regenerate the villi. So in that, because of that, the crypts become hyperplastic and they become deeper. So they become deeper. And third, you see intraepithelial lymphocytes. So lymphocytes, intraepithelial lymphocytes. So lymphocytes go inside the, infiltrate the epithelium. So in lymphocytes go infiltrate the epithelium. Okay. Now, tests, number one, you do a biopsy from the proximal intestine. Okay, and you can do it from the D2, we do it from D2 biopsy, or from, you can even do it from proximal jejunum. Second, you know, we do something called as a D-xylose test. D-xylose test. D-xylose test. Now, what is D-xylose? D-xylose is a sugar, and this sugar, it is absorbed in the small intestine passively. It is not metabolized, it is absorbed, and then it comes in the blood and the urine. It enters the blood and it is passed out in the urine. Now, in case of celiac disease, it cannot get absorbed. So there is an absorption defect. So it's a malabsorption syndrome. So it doesn't get absorbed. So since it is not getting absorbed, it doesn't reach the blood. Since it doesn't reach the blood, its level in the urine are reduced. So normally D-xylose test, D-xylose, if you see, it is passively absorbed in proximal small intestine. Absorbed in proximal small intestine. So D-xylose is normally passively absorbed in proximal small intestine. Now in celiac, since the surface area for absorption has reduced, so D-xylose levels, so it is passively absorbed in the small intestine and it goes to blood and is passed in urine and is detected passed in urine. So it comes out in urine normally. So now in celiac disease, what do you see? In celiac there is decreased absorption, decreased surface area for absorption. So D-xylose is not absorbed, or very little is absorbed, very little comes into the blood. So you have decreased blood and urine levels. So you see decreased blood and urine levels. So decreased blood and urine levels. So in cases where the cause of malabsorption is a defect in the mucosa, or cause of malabsorption is, as we say, bacterial overgrowth can also cause malabsorption. There the D-xylose test will show decreased D-xylose level in the blood or urine. So where the cause lies in the small intestine, D-xylose will not get absorbed and its level in the blood and urine will fall. Another cause of malabsorption is pancreatic insufficiency. In pancreatic insufficiency, small intestine is absolutely normal, but pancreatic enzymes are not available for digestion of food. So in pancreatic insufficiency, because small intestine is absolutely normal, D-xylose will be absorbed and its levels in the blood and urine will be normal. So they will not be decreased. So basically, D-xylose test is done to differentiate causes of malabsorption. To differentiate one of the causes of malabsorption is pancreatic insufficiency. So to differentiate pancreatic insufficiency from cause of malabsorption in the small intestine, where the defect lies in the small intestine, D-xylose test is useful. So in celiac disease, the problem is in the small intestine. So since problem is in the small intestine, D-xylose is not getting absorbed. So since it is not getting absorbed, its urine levels are reduced. Okay, so D-xylose test. So this is about celiac disease. Okay, let us see a picture of celiac. Okay, now this is celiac disease. Okay, so now look at celiac disease. This is what we see. This is normal, and in celiac disease, what has happened to the villi? The villi have become flattened. So there is villus atrophy. So this is villus atrophy. Okay, this is normal. This is normal small intestine here. Normal small intestine. You can see these beautiful villi, and now this is celiac disease. Celiac disease where this is villus atrophy. So what you are seeing here in this picture is villus atrophy. So if you see there is villus atrophy and 2, so villi are atrophy, and 2, second, look at this, this is crypt hyperplasia. So there is villus atrophy and there is crypt hyperplasia here. This picture is showing. Okay, second, this is the pathogenesis of celiac disease, which I have already explained. So gluten contains a compound called gliadin. This gliadin is normally converted by enzyme tissue transglutaminase to deaminated gliadin. In patients with celiac, they have HLA-DQ2 and DQ8. So this deaminated gliadin now acts as a foreign protein, and antigen presenting cells present it to the T cells, and T cells now produce interferon gamma, and this interferon gamma stimulates the B cells to produce autoantibodies like anti-gliadin, anti-endomycin and anti-TTG, and this interferon gamma also cause these lymphocytes, these are T cells to come into the mucosa. Which are these T cells? Usually cytotoxic T cells which damage the epithelium. So now you can see there is loss of villi, increased IELs, means IEL stands for intra-epithelial lymphocytes, and there is elongation of crypt. So all these features of celiac disease can be seen here. There is elongation of the crypt. So this is celiac disease. Okay, so this is about celiac. Okay, next let me come to the second entity that I'll cover with celiac disease is tropical sprue. Tropical sprue is tropical sprue. Tropical sprue is also called, environmental enteropathy. Environmental enteropathy. Also called environmental enteropathy. Now, in tropical sprue, where do you see this? Tropical sprue is usually seen in residents of tropics, people who live in tropics or who have recently visited tropics. So residents seen in residents of tropics, tropical regions, or people who have visited tropics. People who have visited tropics. So residents of tropics or people who have recently visited the tropics. So people who have recently visited the tropics. And if you see biopsy findings in celiac disease, they are same. So biopsy findings in celiac disease, they are in tropical sprue are same as celiac disease. So biopsy finding are same as celiac. That is, in tropical sprue also you have villus atrophy, you have crypt hyperplasia, and you have increased intraepithelial lymphocytes. These are three features of celiac. Villi become atrophied, crypt become hyperplastic, and lymphocytes come into the epithelium. All these three features are seen in tropical sprue as well. But you know, treatment of what is the treatment of celiac? Gluten-free diet. You give them gluten-free diet. But in case of tropical sprue, it does not respond to gluten-free diet. So in tropical sprue, so how do you know this is does not? So does not respond. It does not respond to gluten-free diet. Free diet 1. So tropical sprue does not respond to gluten-free diet 1. 2. There are no autoantibodies. So no autoantibodies in patients with this. So no, they do not have those anti-gliadin, anti-endomycin, so no autoantibodies. in tropical sprue, which we see in celiac disease. And third treatment is now in tropical sprue, they respond to antibiotics. So common antibiotics are, they are given doxycycline and trimethoprim. So treatment is they respond to antibiotics, and antibiotics, so treatment is antibiotics, doxycycline and trimethoprim. And again, sites is same. Tropical sprue and celiac disease, both primarily they affect proximal duodenum, they affect duodenum and jejunum. So in tropical sprue, the site that is involved is usually duodenum and jejunum, but rarely, but can also involve, tropical sprue can also involve ileum. And ileum, if ileum is involved, ileum is the site of vitamin B12 absorption. We know that. Okay, so if ileum is involved, can also involve ileum, and if ileum is involved, then it can produce megaloblastic anemia. So patient can have megaloblastic anemia also. So this is about, and D-xylose test, if you do a D-xylose test, D-xylose test results are same as celiac. So the urinary levels of D-xylose will be reduced because the defect is in the small intestine. So it involves duodenum and jejunum, can also involve ileum. If ileum gets involved, patient will develop megaloblastic anemia. Okay, so this is about tropical sprue. Then coming to the third entity causing malabsorption, third entity is lactose intolerance. Lactose intolerance. Okay, that means people can't tolerate lactose. Milk contains lactose, milk products contain lactose, so they can't tolerate lactose. Why? Because lactose sugar is broken down by an enzyme called lactase. Our small intestinal epithelial cells have this enzyme lactase. So now, cause of lactose intolerance is, this is due to lactase deficiency, lactase enzyme deficiency. So lactase enzyme is needed. Lactase enzyme, Okay, Ayush, you've asked me pathology behind tropical sprue, or pathogenesis of tropical sprue. Okay, exact pathogenesis of tropical sprue is not known, number one. Exact pathogenesis is not known, and it is, since it responds to antibiotics, the cause is probably bacterial, but we don't know the exact pathogenesis, and it is seen in people who usually live in tropical regions. And one of the suspected etiology is, it is usually seen in people who've had a history of repeated diarrhea in first 2 to 3 years of life. So they had repeated diarrhea in the first 2 to 3 years of life. And so since we don't know, so probably it is related to bacterial infection because it responds to antibiotics. But we don't know the exact pathogenesis, but it is associated with going to tropics or living in tropical regions. Okay, lactose intolerance, this is due to lactase deficiency. So now in this lactose intolerance, patients, because they have the deficiency of enzyme lactase is deficient, and if you look at the intestinal villi may be normal, intestinal villi may be normal, may appear normal, there may appear nothing wrong with the villi, but they are not having the enzyme to digest this lactose. So villi are normal, or if lactase deficiency, so villi are normal if lactase deficiency, enzyme deficiency is inherited. However, if lactase enzyme deficiency is due to viral enteritis, viruses can cause lactase deficiency, then the tips of villi will be injured. So villi may be normal, or there may be injury to tips of villi. Tips of villi, if viral enteritis is the cause of lactase deficiency. lactase enzyme deficiency. So if viral enteritis is causing, yes, bacterial overgrowth. Sridevi, you are right, bacterial overgrowth. Pathogenic bacteria, overgrowth of pathogenic bacteria. So villi may be normal, or if the cause for lactase enzyme deficiency is viral enteritis, then tips of villi may show injury. Okay, now what happens? Thus lactose is not digested, because the enzyme lactase is not there. So it is not digested due to deficiency of lactase enzyme. So due to deficiency of lactase enzyme, lactose is not digested. So when lactose is not digested, undigested lactose, it is fermented by the intestinal bacteria. So undigested lactose is fermented. So undigested lactose is fermented by intestinal bacteria. So intestinal bacteria will ferment this undigested lactose, is fermented by intestinal bacteria. This will generate lactic acid. So this is going to generate lactic acid and hydrogen. Hydrogen will be produced. So what will be produced? Lactic acid and hydrogen will be produced. Now this lactic acid will cause osmotic diarrhea. So the child will have osmotic diarrhea. So presence of this lactic acid is going to cause osmotic diarrhea. And then presence of hydrogen. So this hydrogen can be measured by something called, so hydrogen is being generated, and this hydrogen can be measured by hydrogen breath test. So this hydrogen can be measured by hydrogen breath test. So this hydrogen can be measured by hydrogen breath test. Okay, so that's called lactose hydrogen breath test. So now what happens in this hydrogen breath test? You measure. So if post lactose breath hydrogen value, so post lactose breath hydrogen value, so post lactose breath hydrogen value more than 20 parts per million. So post lactose breath hydrogen value, if it is more than 20 parts per million compared to baseline value. So when do we say that the test is positive? You measure this hydrogen breath test. So after giving lactose dose, if the hydrogen breath value is more than 20 parts per million compared to the pre-baseline level, so before pre-lactose value, so if it is more than 20 parts per million, that indicates that there is lactose intolerance. So that is lactose intolerance. Okay, coming to the third part. Okay, Sridevi, what have you asked me? Same way as lactase enzyme intrapicals prove. Okay, why are there you asked me why are there lymphocytes? The interferon gamma is activating CD8 T cells. These CD8 T cells are going into the villi and damaging the villi. Okay, in tropical sprue usually involves duodenum and jejunum, but sometimes tropical sprue can involve ileum. In tropical sprue biopsy findings, you get villus atrophy there also. Okay, but if ileum gets involved in tropical sprue, that can produce megaloblastic anemia because vitamin B12 gets absorbed in the ileum. So it won't get absorbed and there will be megaloblastic anemia. Okay, next cause is pancreatic of malabsorption is pancreatic insufficiency. Pancreatic insufficiency. So pancreatic insufficiency. What is pancreatic insufficiency? Pancreatic insufficiency means exocrine pancreas is not producing enough enzymes. Pancreatic enzymes are very important. Pancreatic enzymes go into the duodenum So they go into the duodenum and in the small intestine, so the pancreatic duct opens at the ampulla of Vater and all the pancreatic enzymes go into the duodenum and they help in absorption of food there. So now if pancreatic enzymes are not available, say pancreas is damaged, it is not producing the enzymes, or enzymes are being produced but there is some obstruction because of which the enzymes don't reach the intestine, then food will not get digested. So food will not be absorbed. So that will lead to malabsorption. So what is pancreatic insufficiency? Pancreatic enzymes not available for digestion of food. For digestion and absorption of food in small intestine. So pancreatic enzymes are not available for digestion and absorption of food in small intestine. Causes of pancreatic insufficiency. Causes are number one, chronic pancreatitis. Alcohol is a very important cause of pancreatitis. So chronic pancreatitis 1. 2. Cystic fibrosis. You know, cystic fibrosis is a disease where thick mucus plugs are formed in the ducts, especially the pancreatic ducts. So these thick mucus plugs, they obstruct the pancreatic ducts and as a result, pancreatic enzymes cannot reach the small intestine. Then third is obstructing carcinoma. So example, carcinoma of head of pancreas. Patients with carcinoma head of pancreas or carcinoma arising at the ampulla of Vater. So what will happen? Pancreatic enzymes cannot reach the duodenum. So So now what will happen? What will you see? There will be malabsorption. So since pancreatic enzymes are not available, there is malabsorption of fat, very important fat, and fat soluble vitamins. You know fat soluble vitamins are A, D, E and K. So there is malabsorption of fat and fat soluble vitamins. Plus they also have developed vitamin B12 deficiency as well as vitamin B12 deficiency may also develop. So this is what. So now diagnosis number 1, you do a D-xylose test. So here now, if you look at the D-xylose test results are normal because D-xylose it is a passive compound. It is a passive substance. Since small intestine is normal, it will get absorbed, its level will rise in the blood and it will be excreted in the urine. So D-xylose test is normal. Whereas in the diseases of small intestine, D-xylose in the urine will reduce. And diagnostic test. What is the diagnostic test? Diagnostic test is you do an abdominal CT scan. So abdominal CT scan. And treatment, what do you give? Treatment is enzyme replacement therapy. So you give them enzyme replacement therapy. So this is about pancreatic insufficiency. So this is number 3, that is pancreatic insufficiency. Coming to the last cause number 4. Okay, fifth cause. So I have covered celiac, I have covered tropical sprue, lactose intolerance, pancreatic insufficiency, and last 5th cause is Whipple's disease. Whipple's disease is also called infectious enteropathy. Causative agent for Whipple's disease it is caused by a bacteria called Trophirema whippleyi. So it's caused by a bacteria which is called as Trophirema whippleyi. So which is the cause? Cause is Trophirema whippleyi is the agent. And you know this Trophirema whippleyi, this bacteria, Whipple's disease actually is a multi-system disorder. So this Trophirema whippleyi infection patient gets Trophirema vipili infection. So Trophirema vipili comes into the blood, enters the blood. Okay. Now from the blood, this Trophirema vipili, it goes to the GI tract, one, and it goes to the extraintestinal. So Trophirema vipili, it goes to the blood. It circulates, it goes to the other parts of the body also. So it goes to the GI tract and it goes to extra GIT sites as well. And it starts to proliferate there. So now it goes to the GI tract and it goes to the extra GIT sites. Extra GIT sites, like it can go to heart to brain. In the brain, it can cause encephalopathy. Then it can go to the joints. It can cause arthritis. So it can go to heart, brain, GI tract. So there can be arthritis, arthralgias. There can be neurological symptoms. There can be cardiac symptoms also. So patient can have cardiac symptoms as well. Okay, now it goes to the GI tract. In the GI tract, this Trophirema vipili, it multiplies. It comes with the lamina propria and it multiplies. So the bacteria proliferates or multiplies, it proliferates in lamina propria of intestine. So it proliferates in the lamina propria. Then, as the bacteria multiplies in lamina propria, macrophages come and eat it up. So the bacteria is eaten by or engulfed by macrophages. So macrophages come, they eat up this bacteria. It's engulfed by macrophages, and these macrophages, they fill the lamina propria. So macrophages fill the lamina propria, and these macrophages, they cause lymphatic obstruction and thus produce malabsorption. So these macrophages fill the lamina propria and cause lymphatic obstruction. The lamina propria has lymphatics, so they cause lymphatic obstruction, and this produces malabsorption. So this produces malabsorption. Okay, so other than lymph nodes, extra GI sites, it goes to the heart, brain, joints, and also lymph nodes. Example, mesenteric lymphadenopathy. It causes mesenteric lymphadenopathy also. It can go to the mesenteric lymph nodes, causing mesenteric lymphadenopathy, and it causes malabsorption. Okay, microscopy. If you do a biopsy from the GI tract, you will find numerous foamy macrophages in lamina propria. So the lamina propria is full of numerous foamy macrophages. And these foamy macrophages, they are pass positive. So in the lamina propria, you have numerous foamy macrophages. They are pass positive. So, or they contain, these foamy macrophages, they contain pass positive bacteria. So they contain these Trophirema vipili, partially digested Trophirema vipili, which are pass positive. And treatment for Whipple's disease, usually again antibiotics. For Whipple's, it's caused by a bacteria. We give them antibiotics like ceftriaxone. 1,2-trimethoprim can be given. So ceftriaxone, trimethoprim, and tetracyclines. So ceftriaxone, trimethoprim, and tetracycline. So now this finishes with what you call as malabsorption, causes of malabsorption. Okay, now let us look at a few questions. Okay, now first look at this 12, what is labeled as 12. This is the characteristic history of pancreatic insufficiency. So a 60-year-old man presents to his primary care physician for pale, foul-smelling stools. So foul-smelling stools. He has history of alcoholism. Very important cause of chronic pancreatitis is alcohol. Alcoholism, though he has not had a drink for past few months. He also has a history of recurrent pancreatitis requiring multiple admissions. Each episode was treated conservatively. He is scheduled for an abdominal CT scan, computer tomography, which shows inflammation and calcium deposits in the pancreas. suggesting chronic pancreatitis. He started on enzyme replacement therapy for pancreatic insufficiency. So this is a type of history that you get in pancreatic insufficiency. Okay, then look at question number 13. A 35-year-old Caucasian female presents with anemia, malaise, bloating and diarrhea. Past genetic testing revealed that this patient carries HLA-DQ2 allele. The physician suspects that the patient's presentation is dietary in cause. Which of the following findings would definitely confirm the diagnosis? A CT scan showing inflammation of small bowel, biopsy of the duodenum showing atrophy and blunting of villi, biopsy of the colon showing epithelial cell apoptosis, liver biopsy showing apoptosis of hepatocyte, esophageal endoscopy showing lower esophageal metaplasia. So very simple answer to this is, so this is a story of celiac disease. This is a story of celiac. So answer to this is, what is the answer to this? Okay, so answer is biopsy. Answer is 2, that is biopsy of duodenum. Oh yes, Ayush, correct. Showing atrophy and blunting of villi. So correct, Sridevi also correct, Ayush also correct. Okay, now this is Whipple's. It's a multisystem disorder where the bacteria can reach the brain causing encephalopathy, lymphadenopathy, malabsorption and diarrhea when the intestine is absorbed. Joint involvement can lead to arthritis. Stools show steatorrhea. Then these Whippli are found, Trophirema Whippli. Where do you find the bacteria? Yes, Abhay, absolutely correct. Pooja, Abhinav, all of you are right. Yes. So the Trophirema Whippli are found within the macrophages. So, and these macrophages, they stain, the bacteria in the macrophages, they stain PAS positive. So this is Whipple's disease. And now this is the microscopy of Whipple's. First, this is PAS stain. PAS stain. And this is normal H&E staining, hematoxylin and eosin staining. And you know, this is the lamina propria. I'll just write LP. This is the lamina propria. All these here, this lamina propria I'm showing with arrow. This is not normal. It is full of macrophages. And this is PAS staining. Again, this is lamina propria. Look at these dark magenta colored bacteria inside the macrophages in the lamina propria. Inside the macrophages in the lamina propria. Okay. Okay. Now let us start with the next entity. Okay. So next now we start with inflammatory bowel disease. Inflammatory bowel disease. So we start with inflammatory bowel disease. In inflammatory bowel disease, I'll be covering 2 entities, that is Crohn's disease and ulcerative colitis. Ulcerative colitis. So Crohn's disease and ulcerative colitis. So I'll be covering 2 entities, Crohn's disease and ulcerative colitis. Okay, first let us see Crohn's disease. Crohn's disease. Okay, now what is Crohn's disease? Okay, Crohn's disease, it's an autoimmune disease. It's a chronic autoimmune disease which can involve any part of GIT from mouth to anus. So Crohn's disease, it's a chronic autoimmune disease. That can, AID stands for autoimmune disease, that can involve any part of GIT. Any part of GIT from mouth to anus. Mouth to anus. So it can involve any part of GIT. So Crohn's disease is a chronic autoimmune disease that can involve any portion of GIT from mouth to anus, but most commonly involves terminal ileum and colon. Terminal ileum and colon. So it involves terminal ileum and most commonly involves terminal ileum and colon. So first, that is involvement, where does it involve? You know, actually second feature. Now in Crohn's disease, you know, usually most commonly involves terminal ileum and there is usually rectal sparing. Rectal sparing. So rectum is usually not involved in Crohn's disease. Rectal involvement, inflammation in the rectum is a feature of ulcerative colitis. So rectum is usually spared in Crohn's disease. That is one. Number two, in Crohn's disease, the bowel involvement is not continuous. The bowel is not involved in its entire length. A part of bowel is involved, then you have intervening normal. Then another part of bowel is involved, then you have intervening normal intestine. So these are called skip lesions. So second, what do you see? We see there are skip lesions. There are skip lesions with intervening normal mucosa. Normal mucosa. So what do you see? You see skip lesions with intervening normal mucosa. Okay, point number 3, microscopy. What do you see? Microscopy in Crohn's disease. Now in Crohn's disease, we see transmural inflammation. So what do you see? You see transmural inflammation. Transmural inflammation. Transmural inflammation means the full thickness of the bowel wall is inflamed. That is the part of the segment of the intestine that is inflamed. Mucosa will also show inflammation. Submucosa will also show inflammation. Muscularis propria or the muscle coat will also be inflamed. Serosa will also be inflamed. So all the 4 layers of intestine are inflamed. Okay, now what will happen? When there is transmural inflammation, what will you see? Number 1, mucosa is damaged. So there will be mucosal ulceration. So what will you see? There is mucosal ulcers. You will see mucosal ulcers. Okay, what type of ulcers? They are to start with, the ulcers are pinpoint or aphthous-like ulcers. So to start with, the ulcers are pinpoint aphthous ulcers. Aphthous ulcers. So what type of ulcers? They are tiny pinpoint aphthous-like ulcers. And then, these ulcers coalesce to form serpentine ulcers. So these ulcers coalesce to form serpentine ulcers. Serpentine ulcers. So now what do you see? There are serpentine ulcers. So now ulcerated area will be depressed, will go downward. So there are tiny serpentine snake-like ulcers like this. Okay. So serpentine area, the ulcerated area will go down. Normal mucosa will protrude up. So this produces cobblestone appearance of the mucosa. So what do you see? This produces the characteristic cobblestone. So ulcerated area is depressed. Ulcerated area is depressed. And normal mucosa is elevated. Normal mucosa is elevated. So now what is this going to produce? This produces what you call as cobblestone mucosa. So this produces what you call as so there are pinpoint ulcers which coalesce to form serpentine ulcers. Ulcerated area is depressed. The normal mucosa protrudes up, producing cobblestone mucosa. Now, second, there is transmural inflammation. So transmural inflammation will cause damage, will damage all the layers. Mucosa, submucosa, muscle coat, serosa, all are damaged. So transmural inflammation causes fistula formation. So there is damage to full thickness of the wall, of bowel wall. So full thickness of the bowel wall, the cells die. Bowel wall, the cells die, and this now produces fistulas. So this produces fistulas. So these patients develop fistulas. So fistula formation is there. So they have fistula formation. Third, now what do you see? Now, since there is inflammation in all the 4 layers, there is transmural fibrosis. So since there is transmural inflammation, chronic inflammation is there. When it heals, there is transmural fibrosis. There is transmural fibrosis. And transmural fibrosis now causes formation of strictures. So now strictures form in the intestine. And the strictured segment, what will happen to the strictured segment? When you do a radiography, when you do a radiology, when you do a barium swallow X-ray, the strictures will appear as string sign. So X-ray, barium swallow X-ray will show string sign. String sign. So the strictured portion will appear as a string. So we'll just see a picture. So that produces string sign on radiology. So you see string sign on radiology. Okay. And microscopy, you are seeing transmural inflammation, and because of this transmural inflammation, all these things are happening. So now there is transmural inflammation, and under the microscope now we see non-caseating granulomas. Non-caseating granulomas. So you see granulomas in the wall of intestine in all the layers. Non-caseating granulomas and lymphoid aggregates. You see lymphoid aggregates. So you see non-caseating granulomas and lymphoid aggregates. Okay, then what are the complications? Complications of Crohn's disease. Now complications are, number one, since there is inflammation in the intestine, food will not get absorbed, malabsorption. So this leads to malabsorption. So this will produce malabsorption. Two, increased risk of colorectal cancer. Okay, now increased risk of colorectal cancer is more with ulcerative colitis. Crohn's usually produces skip lesions. But if there is pancolitis means full length of the intestine gets involved, no skip lesions. Then the risk of colorectal cancer or colonic cancer increases. So this is increased risk of colorectal cancer increased with pancolitis. So normally Crohn's disease doesn't produce pancolitis, it produces skip lesions. Third complication, as we saw, there are fistulas. Patient has fistulas. Okay, which fistulas? Enterovesical fistula. Enterovesical fistula. So fistula connecting the intestine to the bladder. And you know this enterovesical fistula, if they have, their patient can have recurrent UTI. They will have recurrent attacks of urinary tract infection. Recurrent UTI will be there. And you know, recurrent UTI and gas can be passed in the urine. So that is called pneumaturia. So passage of gas in the urine is pneumaturia. So recurrent UTI, passage of gas in the urine. Then fourth, they can also have strictures we have already seen. So strictures, they have strictures. Strictures can cause obstruction. So strictures can cause obstruction. So strictures can produce obstruction. Okay, one more feature here which I have mentioned. Okay, so there is transmural fibrosis. I told you there is transmural inflammation causes transmural fibrosis. So transmural fibrosis causes stricture. 1. 2. When there is transmural fibrosis, you know, so there is fibrosis in the mucosa, fibrosis in the submucosa, fibrosis in the muscularis propria, and fibrosis in the serosa. So when serosa also becomes fibrosed, you know, the mesenteric fat goes and gets stuck on the serosa. So because serosa is fibrosed, now mesenteric fat will go and adhere to the serosa. This is termed as creeping fat. So creeping fat. So what is creeping fat? Creeping fat is because of fibrosis in the serosa. So when there is fibrosis in the serosa, the mesenteric fat will get stuck on the serosa. This is termed as creeping fat. Okay, termed as creeping fat. Okay, so complications we have seen. So these are the complications which the patient can have. Okay, clinical features, how will they present or what are the intestinal manifestations? Patient comes with diarrhea. Diarrhea plus minus blood. So the diarrhea may or may not be bloody. Then patients with Crohn's disease can have extra-intestinal manifestations. So they can have extra-intestinal manifestations. Okay, extra-intestinal manifestations are number 1, rash. So they can develop rash which is called pyoderma gangreosum. So rash called pyoderma. So this is an entity called pyoderma gangreosum. Pyoderma gangreosum or erythema nodosum, something called erythema rososum. Second, they can have eye inflammation in the eye. Eye inflammation, that is because uvea, they can be episcleritis or uveitis. So eye inflammation due to episcleritis and uveitis and episcleritis. Then they can also have oral ulcers. Oral ulcers, that is ephthus ulcers, and also have arthritis. Arthritis is due to, so they can also have arthritis. And kidney stones. So calcium oxalate containing kidney stones. And last is, what is the treatment for Crohn's disease? Treatment for Crohn's disease is, number one, they are given steroids to suppress this inflammation. So it's an autoimmune disease. So you give them corticosteroids 1. Steroids 1. 2, azathioprine. Again, all this to suppress the immune response. Azathioprine. So it's an autoimmune disease, so azathioprine. And then antibiotics. Antibiotics are also given. Antibiotics and other drugs are also given. So this is Crohn's disease. Okay, now let us look at a picture of Crohn's disease. Pictures in Crohn's disease. This is ulcerative. Okay, now these are pictures of Crohn's disease. Okay, now first this is cobblestone mucosa. So now you can see in the center, you can see the cobblestones. So now the ulcerated areas are depressed. So this is cobblestone mucosa, and here these are ulcers. So there are ulcers here. All these where I have drawn the green line, these are ulcerated areas, and remaining mucosa is rising up. So this is diseased tissue is depressed below the level of normal mucosa. So diseases, ulcerated areas, serpentine ulcers are there. So ulcerated area is depressed, normal mucosa is elevated, producing this cobblestone appearance of the mucosa. Second, this is a radiology barium. What you call as so barium study. So this is barium study showing string sign on radiology. So the arrow is showing in both the pictures, arrow is showing the string sign. So this is because of strictures. So string sign on radiology. And this is the picture of creeping fat. So this is creeping fat. So you can see this is the mesenteric fat, and mesenteric fat is going up like this. On the normally mesenteric hangs downwards. So here the mesenteric fat is going up and is getting stuck on the serosa. So this is creeping fat. This is creeping fat. So this is Crohn's disease. And look at this picture again. Okay, now this is Crohn's. In Crohn's disease, these reddish areas are the diseased areas. So you have in Crohn's, you have these skip lesions. And in Crohn's, you can see this picture. You have transmural inflammation, ulcers, and fistulas and fissures are formed. In contrast, after this, I'll talk about ulcerative colitis. In ulcerative colitis, it almost always involves the rectum, and from the rectum it goes to the colon. So it involves rectum and colon in a continuous fashion. So continuous in fashion, no skip lesions. And in ulcerative colitis, you have these large broad-based ulcers. This is a large, so look at the ulcer, it's a large broad-based ulcers. And large areas of ulceration occurs, and then the regenerating mucosa forms pseudopolyps. So we'll again see that regenerating mucosa, we'll see this picture again, regenerating mucosa forms the pseudopolyps. Okay, so coming to ulcerative colitis now. Ulcerative colitis. Okay, looking at ulcerative colitis. Okay, now what is ulcerative colitis? This is also a chronic autoimmune disease. So like Crohn's disease, this is also a chronic autoimmune disease which primarily involves, which causes inflammation and ulceration in the colon and rectum. So this is also chronic autoimmune disease. So it's also a chronic autoimmune disease resulting in inflammation in colon and rectum. Inflammation in rectum and colon. So which results in inflammation in the rectum and the colon. And rectum is almost always involved. Rectum is always involved. So rectum always involved, and the disease involves the rectum and it goes into the colon. That is, from the rectum it will go to the sigmoid colon, then transverse colon, then what you call the ascending colon. So it will go proximally. So rectum always involved, and it involves, and then from rectum it progresses proximally to colon and shows continuous involvement. No skip lesions. So the involvement, in contrast to Crohn's disease, in ulcerative colitis, the bowel involvement, rectum is involved. From the rectum, it goes in an antegrade, or it goes proximally to and involves the colon, and involvement is continuous. There are no skip lesions. That is point number 1. Number 2, now in Crohn's disease, we saw that there was transmural inflammation. In ulcerative colitis, the inflammation is limited only to mucosa and submucosa. So inflammation in mucosa and submucosa only. So inflammation only in mucosa and submucosa. The muscularis propria and the serosa are not involved. So inflammation is limited to. So inflammation is limited to mucosa and submucosa. Okay. Now when mucosa but it is continuous. So when mucosa gets inflamed, there are ulcers are found in the mucosa. So there is mucosal ulceration. What type of ulcers do you get? Large areas of ulceration. So there's mucosal ulceration. There are large broad-based ulcers. Okay, now when you have these large ulcers, then the mucosa starts to regenerate. So regenerating mucosa forms pseudopolyps. So regenerating mucosa forms the pseudopolyps. Okay. So regenerating mucosa now forms the pseudopolyps. Okay. Third, now if you do a radiology, on radiology, what do we see? So on radiology, you see lead pipe appearance or garden hose appearance. So you see lead pipe, which is also called garden hose appearance. Now what is this lead pipe appearance or garden hose appearance? Now this lead pipe or garden hose appearance occurs due to loss of ostrations. This is due to loss of ostrations. So you people already know that in the large intestine we have ostrations. Okay, what are ostrations? If you see large intestine by radiology, it is seen something like this. So these are called saculations or ostrations. These are ostrations. Okay, now in Crohn's disease, in ulcerative colitis, these ostrations are lost and the large intestine appears like this. So there is, what do you see? There is loss of ostrations. So ostrations are lost. So the whole intestine appears like this. So this is called lead pipe or garden hose appearance. Okay, now why are there ostrations and why are they lost here? So now what are these ostrations normally due to? So normal large intestine, this is normal. Normal large intestine has ostrations. Why? In the large intestine we have something called Taenia coli. So this is normal histology with these ostrations, they are due to Taenia coli. What is Taenia coli? It is in the large intestine, you have 3 layers, 3 bundles of longitudinal muscle layers. So 1 bundle, 2 bundle, 3 bundles. So large intestine has 3 layers of 3 bundles of Taenia coli along its length. And the length of Taenia coli is shorter than the length of large intestine. Large intestine is longer. Tinea coli, the longitudinal muscle bundles, the 3 longitudinal muscle bundles, they are shorter. They are shorter. So they act like rubber bands. So what do they act? They act like rubber bands and they pull the intestinal segment like this, and you see these hostrations. So they are these Tinea coli, they are not continuous, they are interrupted. They are interrupted and they pull the act like tiny rubber bands and they pull the intestine, producing these hostrations. Okay, now in ulcerative colitis, what happens? Tinea coli undergo hypertrophy. So they become longer. So tinea coli undergo hypertrophy. It's like you pull the rubber band. So the tinea coli undergo hypertrophy. So when tinea coli undergo hypertrophy, these hostrations are lost. So when they undergo hypertrophy, so their length becomes equal to the length of intestine or they become longer, and as a result now the hostrations are lost. So hostrations are lost. So on radiology, what will you see in ulcerative colitis? We will see loss of hostrations, which produces what you call as lead pipe or garden hose appearance. Garden hose appearance. So lead pipe or garden hose appearance. Okay, microscopy. So this was point number 3. Then fourth, microscopy. What do you see in ulcerative colitis? We see cryptitis and crypt abscesses. Cryptitis and crypt abscess. So I'll show you what it means. So around the crypts there is inflammation. Inflammation of crypts is cryptitis, and when neutrophils enter the crypt, they produce crypt abscess. No granulomas are seen. Okay, then what are the complications? Complications again, here also patient can have malabsorption. Malabsorption because the mucosa is inflamed. There is malabsorption and malnutrition in both ulcerative colitis and Crohn's disease, and increased risk of colorectal cancer. Colorectal CA. So in risk of colorectal CA is more with ulcerative colitis than with Crohn's disease. Then third complication, here you don't have fissures or fistulas. But third complication that we have is what you call as fulminant colitis. Fulminant colitis. Marked inflammation, fulminant colitis. And toxic megacolon. Megacolon. Okay, what is toxic megacolon? There is dilatation of the colon. Dilation of colon. So colon dilates and it can even perforate. So colon dilates. Now why does toxic megacolon happen? You know, the inflammation is confined to the mucosa and submucosa. Sometimes from the submucosa, the inflammation spills into the muscularis propria and it damages the muscularis propria. So the muscularis propria gets damaged, and when the muscle cords gets damaged, the neuromuscular function is disturbed. Neuromuscular function is disturbed and that produces dilatation of colon, that is toxic megacolon. That is fifth. Sixth, clinical feature in intestinal manifestation that the patient will have will be bloody diarrhea. Bloody diarrhea. And seventh now, extraintestinal manifestations. Extraintestinal manifestations. Okay. Same as Crohn's. So the ones which we wrote in Crohn's, like rash, eye inflammation, oral ulcers, arthritis, all can be seen. So same as Crohn's. So same can be seen here also. Plus, very important, add one more very important extraintestinal manifestation. Patients with ulcerative colitis in the liver, they can have sclerosing cholangitis. Sclerosing cholangitis. So they can also have sclerosing cholangitis. So they can have sclerosing cholangitis. So extraintestinal manifestation same plus sclerosing cholangitis. Okay, treatment, what do we give in ulcerative colitis? Treatment is we give them 5-amino salicylic preparations. So we give them number 1, 5-amino salicylic preparations. So 5-amino salicylic preparations, example, mesalamine. Example, mesalamine. So 5 aminosalicylic preparations. Then to suppress the immune response, again you give them, we give them antimetabolites like 6-mercaptopurine. So this is 6-mercaptopurine is an antimetabolite. Then they are given that, and then they are also given agents like infliximab. Infliximab is even given in Crohn's disease. Infliximab, these are monoclonal antibodies. And last, colectomy. Colectomy can also be done. So colectomy is also done. So this is a last option, that is if they don't respond to treatment, and since it has increased risk of developing colorectal cancer, so colectomy is also done in severe cases. So let us look at the pictures of now ulcerative colitis. Okay. Now ulcerative colitis, as I showed you, there is continuous bowel involvement starting from rectum going proximally, and you have these large broad-based ulcers and pseudo polyps. Okay, now let us see a picture of, okay. Now these are pseudo polyps here. So this is pseudo polyps. And this is normal here, and you can see the pseudo polyps, and this is what we call as the garden hose appearance. Garden hose, or so you don't see, you are not seeing any hostrations here. So there is loss of hostrations producing garden hose appearance, or also called lead pipe appearance. So again, these are ulcers and pseudo polyps in this picture, and this is cryptitis. So now normal colon is shown here. These are the crypts. So now what do you see? Cryptitis, first cryptitis means neutrophils surrounding the crypt. So outside the crypt. And crypt abscess means neutrophils inside the crypts. So neutrophils inside the crypts, that is called a crypt abscess. So neutrophils inside the crypts, that is crypt abscess. So this is about ulcerative colitis and Crohn's disease. So now look at this question. A 29-year-old woman presents with colicky, lower abdominal pain, and frequent bloody diarrhea with mucus. Physical examination shows fever and peripheral leukocytosis with multiple stool examinations fail to reveal any ova or parasite. A colonoscopy reveals that rectum and sigmoid portions of the colon have superficial mucosal ulcers with hemorrhage, but regions more proximal are normal and within normal limits. Which of the following histological changes is most likely to be seen in the biopsy specimen taken from her rectum? So now patient has colicky lower abdominal pain, bloody diarrhea with mucus, fever and leukocytosis are the seismic findings, and the rectum and sigmoid colon are involved, and they are showing superficial ulcers. So they are not deep serpentine ulcers, they are superficial ulcers. So what is the answer to this? Okay, yes, Ayush, answer is 1, that is crypt abscesses with crypt distortion and cryptitis. So crypt distortion, crypt abscesses, we distort the crypt. Yes, Yuthika, absolutely correct. So answer is cryptitis with crypt distortion. Then a 39-year-old man presents with bloody diarrhea, multiple stool examinations fail to reveal ova or cyst. Yes, Pooja, you are also correct. A barium examination of the patient's colon reveals a characteristic string sign. A colonoscopy reveals that rectum and sigmoid portion of the colon are unremarkable. Biopsy from the terminal ileum reveals numerous acute and chronic inflammatory cells within the lamina propria. Worsening of patient's symptoms result in emergency resection of distal small intestine. Gross examination of the resected bowel shows deep longitudinal fissures extending deep into the muscle wall. Several transmural fistulas are found. So which of the following is most likely? Yes, Abhinav, you are also correct. Now tell me the answer to this question. What is the answer to this question? Okay, yes, so this is the story. Absolutely, Akanksha, Ayush, Abhay, all are right. So this is the story of Crohn's disease. So this is about Crohn's disease. Okay, so this is the story of Crohn's disease. Okay, now let us come to another entity called irritable bowel syndrome. So Pooja also, yes, all of you are right. So let us come to another entity called as irritable bowel syndrome. Yes, Ashik and Abhinav, yes, all of you are correct. Irritable bowel syndrome. Okay, irritable bowel syndrome. Okay, what is irritable bowel syndrome? Okay, number one, irritable bowel syndrome is an idiopathic and it is a functional intestinal disorder. So there is no organic lesion in the intestine. So it's a functional um, idiopathic gastrointestinal disorder. So it's a functional disorder of GIT and it is idiopathic. It's idiopathic. You don't know the cause. It is idiopathic and it is functional disorder. And here, what does the patient present with? So patient will have chronic abdominal pain. So basically patient has chronic abdominal pain and altered bowel habit and altered bowel habits. So it is a functional disorder. What I mean by functional disorder is, there is no structural abnormality. So there is no structural abnormality. So GI tract is absolutely normal. There is no structural abnormality, and this is more common in middle-aged females. So no structural abnormality, more common in. Okay, so more common in middle-aged females, no structural abnormality, more common in middle-aged females, and associate 50% of these. So associated condition, 50% of these females may have comorbid psychiatric conditions. So associated condition is 50% patients have comorbid psychiatric. So 50% patients have comorbid psychiatric condition. Example, major depression. So 50% of these patients, they have comorbid psychiatric conditions like major depression. Okay, now diagnosis. How do you make a diagnosis? Diagnosis is patient gives history of recurrent abdominal pain. So he'll give the middle-aged female, she'll give you history of recurrent abdominal pain associated. So recurrent abdominal pain associated with two or more of the following. So two or more of the following. Which are these? So history of recurrent abdominal pain plus at least two of the following. Which are these? Pain improves with defecation. Pain improves with defecation, 1. So pain improves with defecation, 1. 2. Change in stool frequency. So change in stool frequency. 3. Change in appearance of stools. So change in stool frequency, change in appearance of stool. And sometimes the symptoms can be diarrhea predominant or chronic or what you call as constipation predominant also. Okay, so this is irritable bowel syndrome where there is no organic defect in the intestine. It is basically a functional defect. So functional defect, and usually they have middle-aged females, and 50% of them have comorbid psychiatric conditions. Okay, then coming to the next entity. Next is appendicitis. Of course, appendicitis everybody knows. Appendicitis. Okay, appendicitis. What is appendicitis? We know the meaning: acute inflammation of appendix. Acute inflammation of appendix. So acute inflammation of appendix is appendicitis. And cause of appendicitis, it can be due to an obstruction due to fecalith. So obstruction of appendix, obstruction due to fecolith. So there is a fecolith which is obstructing the appendix, or in children, you know what happens? Pierce patches, appendix contains lymphoid follicles or lymphoid aggregates. So there can be hyperplasia. So lymphoid hyperplasia. So lymphoid hyperplasia is a common cause of appendicitis in children. So in children, it can be due to, so if you look at the normal histology of appendix contains lymphoid follicles. These lymphoid follicles can undergo hyperplasia and produce obstruction. So now clinical features, patient may have fever, then TLC is raised. Of course, that's not a clinical feature. So fever, leukocytosis, and third is now patient has pain abdomen. Pain abdomen. So patient presents with pain abdomen. And how is this pain? You know, first, initially there is diffuse periumbilical pain. So around the initially, there is diffuse periumbilical pain. Periumbilical pain. So initially it is around the umbilicus, diffuse pain around the umbilical, and then the pain migrates to McBurney's point. Diffuse periumbilical pain, then pain migrates to McBurney's point. McBurney point. So pain migrates to McBurney's point. Okay. Now what is this McBurney's point? Okay. So in addition to pain, patient has fever, nausea, fever and nausea also, and then this pain goes to McBurney's point. So now let us see what is this McBurney's point. Okay. So this is the McBurney's point here, which is drawn. Okay, now what is McBurney's point? 1/3 the distance. So this is the umbilicus. So, and this is the, what is this number 3? This is anterior superior iliac spine. So the number 1, what is marked as 1 is the McBurney's point. That is 1/3 the distance from the right anterior superior iliac spine to the umbilicus. So number 1, this is McBurney's point. So pain, it starts in the periumbilical region and then it goes to the McBurney's point. So McBurney's point is, if you draw a line between the umbilicus and the anterior superior iliac spine, from the anterior superior iliac spine at 1/3 distance you have the McBurney's point. So you have pain migrates to the McBurney's point. And then complications, so they can have patient can, so it migrates to the McBurney's point. And complication is sometimes appendix may rupture and can produce, complication is rupture and peritonitis. So perforation can produce peritonitis. So inflamed appendix can rupture, producing peritonitis. And treatment is appendicectomy. So treatment is remove the appendix, appendicectomy. That is the treatment for acute appendicitis. Okay, let us look at a question. Okay, so before this, okay, now this is a type of history. Look at this. A 34-year-old female presents to emergency department with complaints of intermittent abdominal pain for the past 3 months. She states that the pain has gotten progressively worse over the past 2 weeks. She denies abdominal trauma, hematochezia. Okay, what is the meaning of the term hematochezia? Okay, so she denies any abdominal trauma, hematochezia, heartburn or melena. She works as a corporate lawyer and is currently undergoing a divorce, which has been a large source of stress for her. She does not recall any significant precipitating factor but endorses improvement of pain with defecation. Physical examination was largely unremarkable with mild diffuse abdominal tenderness. So now this is the characteristic history of irritable bowel disease. So patient has this recurrent abdominal pain and pain improves with defecation. There is change in stool, appearance of stool, or change in frequency or appearance of stool. So this is the history of inflammatory bowel disease. Okay, hematochezia. What is hematochezia? Hematochezia is passage of fresh blood through the anus. So patient is passing fresh blood through the anus, which is in the stool or with the stool. So passage of fresh blood in the anus. And you know, hematochezia indicates a lower GI bleed. usually from colon. So if the bleeding is coming from colon, usually lower GI bleed, then patient is going to pass fresh blood into the stools. And melena is black colored stools, and melena usually comes from when the bleeding is at a higher level in the GI tract. It's at a higher level in the GI tract. So, oh yes, absolutely, Abhay. Fresh blood in the stool is hematochezia, and altered blood or black colored stools, tarry stools, black colored stools are melena. Okay, so this is about, okay, now look at this question. Okay, this is the history of appendicitis. A 46-year-old man presents to emergency department with nausea, vomiting, constipation for the past 2 days. He also complains of abdominal pain that initially started in the periumbilical area and then traveled to the right lower quadrant. He is tachycardic, febrile, and mildly hypertensive on examination. A physical examination shows diffuse tender abdomen with rebound, especially at the right lower quadrant, with a rebound tenderness, especially at the right lower quadrant. And then another question, 18-year-old, so this is the type of history that you have in acute appendicitis. Then 18-year-old woman presents with abdominal pain localized to the right lower quadrant, nausea and vomiting, mild fever, and an elevated peripheral leukocyte count of 17,000. So TIC is rates 17,000. Appendicectomy is performed. Which of the following statement best describes the expected microscopic appearance? So very important, histology, what will you see in acute appendicitis? So what is the answer to this? An appendix with normal appearance, neutrophils within the muscular wall, lymphoid hyperplasia and multinucleated giant cells in the muscular wall, a dilated lumen filled with mucus, a yellow nodule at the tip of appendix. So what is the answer to this question? What do you think is the answer to this question? Patient is febrile, Akanksha. Patient has fever. Fever can cause tachycardia. You know, whenever we have fever, high fever, the heart rate rises. Okay, yeah, okay. No, Ayush, answer is not lymphoid hyperplasia with multinucleated giant cells. No. Yes, agreed. Lymphoid in children, lymphoid hyperplasia can lead to acute appendicitis. But if you, what we are asking is, what microscopy, what is the microscopy of acute appendicitis? When will you, okay, answer is not C. What is the answer? What is on histology? What is the characteristic histological feature? If you have a slide of appendix, when will you call it acute appendicitis? Acute appendicitis means in the appendix you should see acute inflammatory cells, that is neutrophils. Okay, where neutrophils? So, you know, appendix also has a mucosa, a submucosa, a muscle coat, and a serosa. Yes. Now, you know, normally also in the appendix, in the mucosa and submucosa, you can have neutrophils. That is normal. But if you are seeing neutrophils in the muscle coat of appendix, muscularis propria, then a diagnosis of acute appendicitis is made. So answer is neutrophils within the muscular wall. Muscular wall means in the muscle coat. So if you see acute inflammatory cells, that is neutrophils in the muscularis propria, in the muscle coat, in the muscular wall, only then you diagnose acute appendicitis. Cause of acute appendicitis can be fecolith or lymphoid hyperplasia, but you won't get these multinucleated giant cells. So answer is B, neutrophils in the muscular wall. So that is what we see in acute appendicitis. Okay, after this, okay, I'll finish my class here. After this, I have to start with diverticulitis. Rest of the diverticula and then other parts of GIT are left. Diverticula, we have polyps of the colon, then we have colorectal cancer, and then we'll start with liver. So we'll cover liver and pancreas. Yes, Ayush, perforation can occur both with gastric. Okay, perforation can occur in gastric ulcers also. Absolutely correct. Perforations can occur, I have written duodenum. Uh, as compared to gastric ulcers, duodenal ulcers, perforation is more common. Perforation is more common. Okay, and which anterior wall ulcers are more likely to perforate? Anterior duodenal wall ulcers are more likely to perforate. So you are absolutely right. Perforation can happen in gastric ulcers also, but perforation is more common with duodenal ulcers. And in the duodenum, the ulcer in the anterior wall of duodenum is more likely to ulcerate, and the ulcer in the posterior wall of duodenum is more likely to bleed. So complication of both gastric and duodenal ulcers is bleeding and perforation. And the ulcers located in the pylorus of the stomach and the duodenum can also cause obstruction. Okay, any other questions? Any other questions? So in the next class, I'll finish in GIT and start with liver. Okay, so good night all of you.